So good morning and welcome you all for the another edition of Online Anaesthesia Postgraduate Teaching Program and Zoom platform, sponsored by Aquila and hosted by A1 Logics. Today we have two lectures followed by a video session. The first topic is preoperative assessment of cardiac patients for non-cardiac surgeries by Dr. Guru Sandhya. That will be followed by anesthesia for congenital heart disease by Ranjit Karthikeyan. I have to thank Ranjit for accepting our invitation between his busy schedule. Then with the video session, we are having ultrasound guided blocks for chest wall surgeries by Dr. Divesh Arora. I have to thank Divesh sir for accepting our invitation for the second time, because his first video is very big hit, you all know. So this session will be coordinated by Sarve Vinodini. So I invite first speaker Dr. Guru Sandhya to deliver a lecture on preoperative assessment of cardiac patients for non-cardiac surgery. Over to Guru Sandhya.
Thank you, sir. Very warm good morning to one and all. Today I'm going to present on pre-anesthetic evaluation of a cardiac patient for a non-cardiac surgery. So, as we all have known, we have been showing some persistent interest towards a cardiac patient presenting for a non-cardiac surgery. Why is that so? The number of patients, cardiac patients, who are presenting for non-cardiac surgery is on the rise, and these patients are responsible for all-cause mortality about 45%, and the cardiovascular incident is related to it, and they are having an increased incidence of perioperative MI and heart failure. Hence, there has been guidelines from American Heart Association, Canadian Society of Cardiologists, and European Society of Cardiology for perioperative optimization and risk stratification and risk mitigation in such patients. The spectrum of cardiovascular diseases not only include IHD, but also includes hypertension, the patients after presenting to us with the percutaneous coronary intervention, patients with heart failure, valvular abnormalities, patients with cardiomyopathies, and rhythm abnormalities. Before proceeding to any other topic further, we actually have to evaluate the patient first in terms of history. What is the presenting complaints of the patient, and personal history would relate them with the smoker being or alcoholic. Pertaining to cardiac etiology, any history which would suggest towards a cardiac etiology like chest pain at rest or on exertion, pointing towards a myocardial ischemia or angina, or dyspnea on exertion or dyspnea at rest, palpitation, syncope has to be taken clearly in case of a cardiac disease which we are dealing with. In case of an examination pertaining to cardiovascular system, we can look for if the patient has got any murmurs in the heart or a third heart sound, or any examination which can include elevated JVP or pedal edema or pulmonary Krebs and S3 gallop. And you also have to look for the pulse volume and character to determine any cardiovascular problem which the patient may have got. One persistent importance in these days is being given to effort tolerance. Any patient who may be an ischemic heart disease patient, but if their effort tolerance is more than 4, then they can actually undergo non-cardiac surgery with limited risk than the patient who has got less effort tolerance. So what is the proposed procedure which the patient is undergoing, and what is the risk of the non-cardiac surgery which the patient is undergoing? What are the medications the patient is on? How do you risk stratify them, and how do you mitigate the risk? And one important point to note is whether you proceed with the non-cardiac surgery first or you proceed with the cardiac procedure first. Do you want to evaluate further or do you want to go ahead? This is what we'll be dealing in this presentation. So in case of a patient who has got no history of an ischemic heart disease, prudency must be applied to all these factors which may point out to a underlying ischemic heart disease, like patient being a smoker, hypertensive, who has a hyperlipidemia, and advanced age, who has a history of chest discomfort on and off, dyspnea at rest, an ECG showing a strain pattern or an ischemic change. And in non-IHD, we have to put our front towards the chest discomfort or angina equivalent, which may be dyspnea on exertion and angina. Before proceeding to topic further, we need to delineate about certain important parameters which we are going to see. That is the urgency of surgery. Any surgery which has to be taken within 6 hours when the patient presents, that is a limb-threatening or life-threatening surgery, is defined as an emergency surgery. Any surgery which has to be taken within 6 to 24 hours, as in a case of an acute intestinal obstruction or a hip fracture or so, that becomes an urgent surgery. Any life-threatening or limb-threatening which has to be taken within 24 hours. Then comes the time-sensitive surgery, which takes around, you can wait for 1 to 6 weeks. Most oncological surgeries fall under this category because more than 6 weeks, if they wait, the risk of metastasis may be high. And elective surgeries, you can wait for and decide, maybe a cosmetic surgery or a liposuction or a lipoma excision, anything which is not complicated can wait for a year or so. That is defined as an elective surgery. And the risk of non-cardiac surgery is also important because this surgery itself is associated with an increased risk of perioperative major adverse cardiac events. Any surgery with less than 1% risk of MACE is defined as a low risk surgery. Intermediate risk is 1 to 5%, and more than 5% is a high risk surgery. Any open vascular aortic surgery, liver resection, adrenal resection, pneumonectomy, and Whipple surgery is defined as a high risk surgery in respect to MACE. And minor gynecological procedures, superficial surgeries are defined as low risk surgeries in MACE point of view. Coming on to the disease proper, the first one is hypertension. In AHA guidelines 2017, any BP of more than 130/80 is defined as hypertension. May it be primary or secondary hypertension, and the cause has to be exactly known. And the patient may present to us with an end organ damage or remodeling like left ventricular hypertrophy, ischemic heart disease, and chronic kidney disease secondary to hypertension. The patient might previously have got an intracerebral hemorrhage or can be coexisting with the peripheral artery disease. In preoperative evaluation, it is imperative to look for ECG to see for any left ventricular hypertrophy and creatinine to know the end organ damage. In case of medications, you withhold ACE inhibitors and ARBs and continue all other antihypertensive agents in the perioperative period. Coming on to a case scenario, he is a 58-year-old male posted for an elective surgery and he's a hypertensive for 10 years. ECG shows signs of LVH and creatinine is normal, but the BP is somewhere around 190, 110. But in this case, will you proceed? International guidelines have suggested that any BP of more than 180/110 is associated with increased cardiovascular risk. But there is no compelling evidence to suggest that if you defer this surgery, it is associated with improved perioperative outcomes. So you decide upon what the surgery patient is posted for, and then decide whether you want to defer the surgery or you want to continue the surgery. In case of an ischemic heart disease, our perioperative goal is to find out is any undiagnosed ischemic heart disease which the patient might have got. If the patient is a known coronary artery disease patient, what is the severity? What is the functional limitation which the patient presents to us? What is the therapy the patient is getting? And what are all the preoperative investigations you would order? Do you need any additional testing to find out if the patient can improve in the perioperative period? And how do you reduce the risk reduction? According to Miller 9th edition, recently there was a question asked in Telegram. You defer any elective non-cardiac surgery for 2 months following a myocardial infarction, not requiring a PCI, not done a PCI. So it's 2 months. And in the risk assessment, there are a number of guidelines which have come, risk stratifications which have come, and the time-tested one will be a revised cardiac risk index. And nowadays there is a preponderance towards NSQIP, myocardial infarction, and cardiac risk calculator. And these are the guidelines which are available: AHA guidelines, ESA guidelines, and Canadian Society guidelines. Coming on to Goldman Cardiac Risk Index, it is a 9-point index which is actually retrospectively developed in 1977, involving 1,001 non-cardiac patients. Pertaining to history, it is MI less than 6 months carries 10 points, age more than 70 years carries 5 points, and in the physical examination, S3 gallop carries 11 points, signifying heart failure, and significant aortic stenosis carries 3 points. Rhythm other than sinus carries 7 points, more than 5 EPCs per minute carries 7 points, and poor general condition and intraperitoneal or intrathoracic or aortic surgeries carry 3 points, and emergency surgery carries 4 points, and the total is around 53. Any class 1 is 0 to 5 points carries 1% risk. Class 2 is 6 to 12 points carries 7% risk. Class 3 is 13 to 25 points, carries 14% risk, and class 4 is more than 26, carries 78% risk of MACE. Coming on to Lee's revised cardiac index, this consists of 6 components. The components include high-risk surgery, which may be intraperitoneal, intrathoracic, or suprainguinal vascular surgeries, or any history of ischemic heart disease like history of MI or an abnormal ECG, history of chest pain, usage of nitrates, and an ECG having a pathological Q wave. In case of history of congestive cardiac failure, we have to look for prior history of congestive cardiac failure, pulmonary edema, or now the chest is congested with the pulmonary rales, paroxysmal nocturnal dyspnea, or a chest X-ray showing a pulmonary vascular redistribution. And history of cerebral vascular disease, diabetes mellitus requiring insulin, and a preoperative creatinine of more than 2. Each of it is assigned 1 point, and it is a 6-point scale. Any point is 0 carries 0.4 risk of MACE, 1 carries 1% risk of MACE, 2 carries 2.4% risk of MACE, and more than 3 carries 5.4% risk of major adverse cardiac events. And this is one of the time-tested cardiac index, which is developed in 1999, and it is externally reevaluated so many times. And it has very poor discrimination in vascular surgery per se, because the study subjects were not included and it is a moderate risk determination index. It is also included in AHA guidelines and CCS guidelines, and it does not rule out all-cause mortality, but it rules out only the cardiac morbidity and mortality. Coming on to ACS QIP surgical risk index, it's a 20-point scale, and MICA is myocardial infarction and cardiac arrest scale. This includes 5-point scale, which includes age, ASA physical status, preoperative function, preoperative creatinine, and the proposed procedure. It is a percentage scale from 0 to 100. 0 is lowest risk and 100 is the highest risk. This is actually based on a very larger set of data than RCRI, and it predicts all-cause mortality and MI within 30 days, and it is not externally validated. Postoperative troponin were not taken into consideration, and so no systematic monitoring events were available. So it actually underestimates the risk than RCRI, and it is also suggested in AHA guidelines. So next is a set of patients who will come to us with a percutaneous coronary intervention. May it be a patient who has undergone a balloon angioplasty or has a bare metal stent or a drug-eluting stent. So why are these patients of special concern to us? Prior they were doing balloon angioplasty. So any vascular intervention reads in an endothelial injury, and the response to it is endothelial revascularization or re-endothelialization. In balloon angioplasty, this re-endothelialization was not controlled. Even then came the bare metal stent, which had again a tight intact lumen. But in this also, the intimal proliferation, as you can see, the intimal proliferation within the stent is not controlled. Then came the drug-eluting stents, which had antimitotic drugs in place to check this neointimal hyperplasia and to prevent any stent thrombus which would occur. So that is why these stents require a minimal period of dual antiplatelet agents or antiplatelet agents to make them mature, and also to check the neointimal hyperplasia which would occur. So nowadays, more of the patients with coronary interventions are presenting to us for non-cardiac surgery. And these stents are important because any dual antiplatelet stoppage within the proposed period can actually lead to increased risk of stent thrombosis. Hence, these patients are of important to us and in the perioperative consideration, because stopping the antiplatelets may lead to stent thrombus, but continuing the antiplatelets may lead to increased postoperative bleeding. So time interval for coronary intervention and NCS has been developed. Any non-cardiac surgery, time-sensitive surgery can be taken 2 weeks after balloon angioplasty, 30 days after bare metal stents. Now the guidelines recommend after 6 months, if the surgery is non-deferrable, you can go after a drug-eluting stent, and it is possibly limited more than 1 year. And it is better to undergo any elective surgery more than 1 year if it is a drug-eluting stent. In the interim period, the patient should be on the antiplatelet agents as suggested by the cardiologist. So in case of a patient with a coronary stent, maybe a bare metal stent or a drug-eluting stent, the continuation of antiplatelets depend upon the thrombotic risk of the percutaneous coronary intervention and hemorrhagic risk of a non-cardiac surgery. In case of a thrombotic risk, low risk the thrombotic risk for PCI is low if there is more than 4 weeks for balloon angioplasty, more than 6 weeks for 6 months for bare metal stenting, and more than 12 months for drug-eluting stenting. The thrombotic risk of PCI is intermediate if it is 2 to 4 weeks following balloon angioplasty, if it is 1 to 6 months following a bare metal stent, and it is more than 6 months and less than 12 months following a drug-eluting stent. And the thrombotic risk of a percutaneous coronary intervention is very high when you do a non-coronary surgery or stop the antiplatelet agents within 2 weeks after a POBA, or less than 1 month after a bare metal stent, and less than 6 months with the drug-eluting stent. The hemorrhagic risk of non-cardiac surgery must be considered in the perioperative consideration, wherein hepatic resection, Whipple's, TURP, TURBT, prostatectomy, open thoracic surgeries are all associated with high risk of bleeding. And the low risk may be any urological procedure, arthroscopy, cystoscopy, and vascular surgeries like carotid endarterectomy and EVAR and TVAR or limb amputation, wherein you can secure the bleeding points easily, are considered as low risk for hemorrhagic propensity in the perioperative period. So perioperative continuation of dual antiplatelet agents depends upon thrombotic risk versus hemorrhagic risk. If the thrombotic risk is low, you continue aspirin, whatever may be the hemorrhagic risk. You discontinue clopidogrel. You resume within 24 to 72 hours with the loading dose. If the thrombotic risk, as you can see, is intermediate, again, if it is an elective surgery, you postpone the surgery for more than 1 year. But if it's a non-deferrable surgery, you continue aspirin and withhold P2Y12 inhibitors and resume within 24 to 72 hours following a loading dose. And it happens so for any hemorrhagic risk which can happen. But if the thrombotic risk is very high, but the hemorrhagic risk is low, you try to postpone. If it is non-deferrable, you continue aspirin and clopidogrel together and mitigate the bleeding which can happen in the perioperative period. But if the thrombotic risk is high and the hemorrhagic risk is intermediate or high, then you continue aspirin, withhold clopidogrel. You can continue bridging or consider bridging with the short-acting IV antiplatelet agents like tirofiban, eftifibatide, or cangrelor. I have only personally used tirofiban. I don't think these two are available yet. In case of short-acting IV antiplatelet agents, there is still no large number of data which is available to say if you bridge with IV bridging, the perioperative risk of major adverse cardiac events is less. Still, there is limited data on usage of IV antiplatelet agents, but for the sake of the theory, we just have to know that IV antiplatelet bridging has to be done in a patient who has a high thrombotic risk. So how do you bridge it? For prasugrel, you stop 7 days before. For clopidogrel and ticagrelor, you stop 5 days before. On the third day, you start them on tirofiban at an infusion of 0.4 micrograms per kg per minute. And then you just stop it 4 to 6 hours prior to surgery, because the offset time for tirofiban is 4 to 6 hours. Once when the surgery is over, after 4 to 6 hours, you can actually, if the bleeding risk is very less, you can try to resume clopidogrel with a loading dose of 300 to 600 milligrams. And if the bleeding risk is high, you can continue with small like IV antiplatelet agents, or withhold the antiplatelet agent and stop when the bleeding risk is mitigated. You follow them up to discharge and decide whether to continue with dual antiplatelet agents or so. Coming on to next subset, who is a heart failure. So heart failure can be with the preserved ejection fraction. These patients actually have a lower adjusted mortality than the patients who have got a heart failure with reduced ejection fraction. In patients who have heart failure, you delay any elective procedure for at least 1 month. If it's an urgent procedure like an intestinal obstruction or a hip fracture, then you delay the procedure for at least 24 hours if it is feasible. And any elective high cardiac risk surgery, you have to defer it for at least 3 months of a newly diagnosed heart failure patients. In these heart failure patients, the perioperative goal is to find out whether they are compensated or uncompensated. You can very well find this out from the history and the examination, and how is the effort tolerance of the patient. In the examination, you look for pulmonary rales, chest congestion, S3 gallop, elevated JVP, pedal edema, and in the history, you look for anything like shortness of breath, cough, paroxysmal nocturnal dyspnea, and so. In the investigations pertaining to heart failure, this has shown a significant propensity to diagnose the patient on who have got failure, that is NT-proBNP, and echo to rule out any new insult which has occurred. In the perioperative period, it is imperative to continue drugs like hydralazine, nitrates, digoxin, diuretics which the patient may have got, and certain patients may be on anticoagulation or implantable cardiac defibrillator. This has been extensively discussed in the previous lecture, and anticoagulation in the form of warfarin has to be bridged in the perioperative period to heparin and then treated accordingly. Coming on to the next subset of patients with prosthetic valves. In any case of prosthetic valve patient who presents to us in the perioperative period, you see what is the underlying pathology for which the patient has got the valve replacement. You see the type of the valve, whether it's mechanical valve or a biological valve. What is the current status of the valve? What is the functional status of the patient following a valve replacement? What anticoagulation the patient is getting, what vitamin K antagonist like warfarin, what is the targeted INR for the patient which the cardiologist aims for. These patients, particularly, you have to look for hemolytic anemia, which can happen secondary to the valve. You have to look for if the patient is jaundiced and LDH and peripheral smear to rule out hemolysis. And echo, if it is recently available less than 3 months, you can actually go ahead with that echo, and if there is no difference in the functional status of the patient. So what are we more worried about this prosthetic valve is, how is the prosthetic valve function and the valve thrombus. The prosthetic valve thrombus is itself is a life-threatening situation wherein the prosthetic valve in mitral area has got a propensity to thrombose more than the aortic valve, and the risk is more in the first 3 months to 6 months, and then the risk slowly mitigates on its own in the due course of time. So this is an AHA guideline for continuation or withdrawal or bridging of perioperative anticoagulation in case of a mechanical valve and the bioprosthetic valve. In case of a mechanical valve, the patient usually will be on a warfarin anticoagulation. In case of a mechanical AVR with no other risk factors, if the patient needs aspirin, the patient will be on aspirin also in the perioperative period. The goal is for 2.5 INR. But in the perioperative period, if it's a mechanical AVR with no other risk factors, then no bridging is necessary. You can stop warfarin, bring the INR to subtherapeutic levels, do the surgery with minimal risk of bleeding, and bridge the patient in the postoperative period and start on warfarin. In case of mechanical AVR with other risk factors are the patient additionally has an AF or has a prior thromboembolic manifestation, or the patient has a hypercoagulable state or has a reduced ejection fraction. All these patients and mechanical mitral valve patients, the therapeutic INR goal is around 3. In these patients, perioperatively, you stop warfarin 5 days before. You bridge it either with low molecular weight heparin or heparin, unfractionated heparin. If it's low molecular weight heparin, if it is a prophylactic dose, you stop within 12 hours before surgery. If you're using a therapeutic dose, stop 24 hours before surgery. And if it's an unfractionated heparin, stop 6 hours before surgery and proceed to elective surgeries. Once when in the first 24 hours, the bleeding risk is low, you start them on heparin again and bridge with warfarin in the second day and stop the low molecular weight heparin or heparin in the postoperative period. In case of a bioprosthetic valve, initial 3 to 6 months, the patient will be on warfarin and then bridge to aspirin. So biological valve, the patient will be on aspirin, and in the perioperative period, it is okay to continue aspirin in those patients. So coming on to valvular heart disease, the patients with valvular heart disease usually has been evaluated for in the history itself for all the same. We are in specific, we have to look for how is the RV or LV responding to the overloading conditions and how is the pulmonary artery systolic blood pressure. So in case of an AS, it becomes very tricky for us to handle between a aortic valve and a non-cardiac surgery. If the patient is symptomatic, you actually try to mitigate and postpone the elective surgery if it is possible. If it is a severe valvular AS and a critical patient, the risk of non-cardiac surgery, if it is low, then the perioperative risk may be low. If the risk of non-cardiac surgery, if it is intermediate or high, then the patient is actually going to have a very increased risk in the perioperative period. So based on the severity of aortic stenosis, if it is an urgent surgery with hemodynamic monitoring and increased perioperative risk, we just have to go ahead because there is no other rule. In case if the patient is going to undergo a high risk non-cardiac surgery, say Whipple's, then you consider a balloon valvuloplasty, which is safer. In case if the patient is asymptomatic and has only undergoes only moderate to low risk surgery, it can be performed with an increased risk of perioperative events of MACE. But if the patient is severely symptomatic, you just have to sit with your cardiologist and team and consider doing a trans aortic valve implantation before the non-cardiac surgery, which is going to take place if the surgery is going to be a high risk surgery and the patient is going to be a severely symptomatic patient. But suppose if the TAVI itself has a high risk than the non-cardiac surgery, then you go with non-cardiac surgery with a strict monitoring. In case of valvular MS, when to proceed with non-cardiac surgery and when to proceed to percutaneous intervention. In case if the valve area is more than 1.5 and the patient even having a significant stenosis is asymptomatic and the pulmonary artery systolic pressures are less than 50 millimeters of mercury, then you can proceed to NCS with NCS is non-cardiac surgery with the increased risk. But if the patient is symptomatic with the severe MS or if the systolic pulmonary artery pressure is more than 50, then you will definitely have to talk with your cardiologist about doing a percutaneous mitral valve commissurotomy before doing a non-cardiac surgery. In case of regurgitant lesions, say it be a mitral regurgitation or aortic regurgitation, if the lesions are not significant and if the patient is not symptomatic with a severe MR or a severe AR and has a preserved ejection fraction, then these subsets of patient may not pose an additional risk. But if the patient is symptomatic with a severe AR and severe MR and has a reduced ejection fraction of less than 30% or systolic pulmonary artery pressure more than 50 millimeters of mercury, then these patients are at increased cardiac risk for a non-cardiac surgery. You optimize them in the perioperative period for measures to decrease the amount of load which the patient is struggling against. If the criteria for valve replacement fit in and if the non-cardiac surgery can wait, it is prudent to go for a valve replacement than the non-cardiac surgery. So coming on to rhythm abnormalities, the rhythm abnormalities include AF with fast ventricular rate, and this actually denotes a significant arrhythmias, and lethal arrhythmias or potential ventricular arrhythmias actually signify a significant arrhythmias which can occur in the perioperative period. So in AF with fast ventricular rate, what you aim for is rate control, and the preoperative period look for if the patient is previously on any anticoagulation, bridge it as and when necessary. In case of symptomatic bradycardia and high-grade AV block, these patients will require permanent pacemaker before any elective non-cardiac surgery. In case of bundle branch block, these can be either due to age-related fibrosis in the conduction system itself or signify a underlying pathology. In such cases, if there is RVVB, rule out any do an echo, rule out any pulmonary valve dysfunction or right ventricular systolic dysfunction or any pulmonary disease which is precipitating a right bundle branch block. In case of LVB, rule out any myocardial ischemia which has triggered the left bundle branch block. In case of supraventricular arrhythmias preoperatively, like Wolff-Parkinson's-White syndrome, you have to avoid drugs which will block the conduction across the AV node in the perioperative period and continue whatever antiarrhythmics which the patient is getting and mitigate the arrhythmia accordingly in the perioperative period. In case of ventricular arrhythmia, it can be a benign ventricular premature complex, as which can occur in any older individuals or so. Potentially lethal arrhythmias include non-sustained VT. Any VPC is more than 5 per minute or more than 30 per hour. These may actually signify, or multifocal VPCs, these may actually signify a underlying myocardial damage or signify any electrolyte abnormalities like hypokalemia or hypomagnesemia, which can be treated. And lethal arrhythmias include sustained ventricular tachycardias and resolve into normal sinus rhythm. This lethal ventricular tachyarrhythmia will require a placement of implantable cardiac defibrillator before undergoing any non-cardiac intervention, which is elective. So coming on to next subset of patients who will present to us is a cardiomyopathy. Cardiomyopathy may be dilated ischemic cardiomyopathy, which happens secondary to myocardial ischemia, and the related mitral regurgitation can be treated by reducing the load which the patient is getting against. The next thing which can present to us is a hypertrophic obstructive cardiomyopathy, may it be primary or secondary to a hypertension, concentric LVH, then leading on to hypertrophic cardiomyopathy. The thing which we are bothered about is the dynamic left ventricular outflow tract obstruction and the mitral regurgitation, which happens secondary to systolic anterior motion of the mitral valve. You look for specific signs and symptoms like exertional dyspnea and syncope. Some patients may be on implantable cardiac defibrillator because of the sudden syncopal attacks which they've got and sudden cardiac arrest which they have encountered before. And these patients mostly on HOCM will be on negative inotropic agents, and it is imperative to continue that beta blockers in the perioperative period as well. So coming on to whole lot of preoperative investigations which we will do. Any patients who's coming for a non-cardiac surgery, may be an intermediate or high risk surgery, we look for the presence of anemia and for the platelet count. So CBC becomes an absolute necessity in such patients because anemia can trigger a perioperative myocardial insult. And renal function test to look for any cardiorenal syndrome. Liver function test only in pertaining patients where they have got a congestive hepatomegaly or so. Serum electrolytes in patients who are on diuretics, on AC inhibitors or ARBs, and any arrhythmias which can be potentiated in the perioperative period to look for and to treat hypokalemia if at all it is there. And Canadian guidelines actually suggest to do a preoperative NT-proBNP and BNP for age more than 65 years or any patient who has got a cardiac history prior. They advise them to undergo NT-proBNP in the preoperative period. In case of a heart failure or you doubt any hemodynamic compromise, ABG can be done to rule out any acidosis which is pre-existing. In case of an ECG, if you doubt that the patient may have a LVH in case of a hypertension, all those patients can undergo an ECG. But if the patient has just taken an ECG 3 months back with no change in the functional tolerance or effort tolerance, then you need not subject the patient to another ECG, and you can very well go ahead with the same ECG which the patient has taken 3 months prior. So what are the guidelines for echo? Any dyspnea of unknown origin or any patient who has got priorly done an echo, but now the functional limitation is more than before, then to quantify what has happened, you can actually do a perioperative echo. In history, if anything is suggestive of an obstructive disease like Hockham or a severe valvular disease or severe LV dysfunction like dyspnea at rest, then you can actually go ahead do an echo even in the surgery which is emergency or urgent. And in case you want to reassess the LV, the patient has got a severe LV 1 year back and you want to reassess the LV. Now it has been 1 year, the patient is coming for a non-cardiac surgery, then you can actually go ahead do an echo. Then ECG for X-ray stress testing and stress echo. This can be done if the patient is not able to mobilize. Say the patient has got an OAME, functionally incapacitated patient, but you want the patient is undergoing a high-risk non-cardiac surgery. Then you may subject them towards a stress echo and stress ECG because this will alter the perioperative course. Routine CT angiography, coronary angiography for a patient with IHT is not recommended and it overestimates the risk. Coronary angiography and revascularization depends upon individual patient-based diagnosis and management. If the patient has got significant angina or chest pain at rest, suggestive of myocardial ischemia with ECG changes or troponin, in a time-sensitive surgery, then you can actually go and do a coronary angiography based on the risk stratification. And Postoperative troponin is actually recommended in Canadian guidelines for 48 to 72 hours daily serial monitoring. They have suggested that most of the myocardial injury following non-cardiac surgery is actually asymptomatic. So only then you check a postoperative troponin level will then it alter the course of the perioperative period in the patient who has undergone a non-cardiac surgery. So any patient who is undergoing a non-cardiac surgery which is of high risk, it is better to do a postoperative troponin levels. So which are the drugs to continue and which to withhold? Beta blockers, it is always prudent to continue. Diuretics, you can continue unless the surgery is going to involve a significant blood loss or significant fluid shifts. It may be for hypertension or heart failure. Now their recommendation is to stop ACE inhibitors, ARBs for 24 hours before surgery and to restart them as and when the patient becomes hemodynamically stable after 24 hours. Any anticoagulants like warfarin, you bridge them with heparin if at all it is necessary, and then stop heparin 6 hours or 12 hours depending upon the heparin which you are using and mitigate the perioperative bleeding. Coming on to antiplatelets, as we have discussed earlier, there are guidelines to continue aspirin and clopidogrel in case if the surgery is stopped or if the patient is undergoing a closed neurosurgical procedure, then it is actually prudent to stop aspirin also because the fatality risk, bleeding fatality risk is high if the patient is continued on aspirin in such procedures. In such procedures alone, you need to stop aspirin and continue in the perioperative period, postoperative period. Any antiarrhythmic the patient is on, you have to continue. Nitrates, calcium channels, and statins also to be continued to decrease the risk of perioperative major adverse cardiac events. The recommendation is very strongly against starting a beta blockers within 24 hours according to POISE study. Any perioperative starting of aspirin, alpha blockers, or calcium channels blockers for the sake of only mitigating the perioperative risk of the cardiovascular events, it is not at all recommended. And coronary revascularization for stable cardiac disease is not recommended. So I've got 3 case scenarios to end the session with. The first case scenario is a 58-year-old hypertensive who has a known IHT. He has met with an RTA and has a vascular injury, which threatens his lower limb. So the patient already has a ischemic lower limb. So this becomes a emergency surgery. In the history, there is MI less than within 2 months and he is on medications. The medication history is not known and his effort tolerance has been 4 meds and has remained the same even in the before the RTA. There is no history suggestive of acute heart failure like chest pain or dyspnea or so. His echo taken 2 months back had good LV and no regional motion abnormality. Even though the patient has got MI in 2 months, this surgery is an emergency surgery which is threatening his lower limb. So you do not do any further investigations because 2 months before echo is normal and the effort tolerance has also been normal. So you actually subject the patient to the surgery depending upon the medications which he is taking. It can be a regional anesthesia or general anesthesia. Case 2, he's a 79-year-old smoker with IHT and COPD, posted for an elective non-cardiac surgery. He has exertional dyspnea and palpitation, which is worse than before, and no investigation of the past year is available. So on examination, he has AF with fast ventricular rate, which I said, by the way, is a significant arrhythmia in the first time noted in the perioperative period or preoperative assessment. AF with fast ventricular rate with a borderline BP. And in such cases, when there is significant arrhythmia, when this elective surgery can wait, you actually postpone and evaluate the cost and then take the patient up for the non-cardiac surgery. Case scenario is a 60-year-old female who is a diabetic on insulin, posted for Whipple surgery. So this surgery is a high-risk surgery and has a history of TIA. So that makes RCRI 0.2 and has a diabetic on insulin. So RCRI is 3 points. So the effort tolerance is more than 4. ECG and echo is within normal limits. So the RCRI is 3. The procedure itself has more than 5% risk of MACE. And it is a 5.4% risk of MACE is the RCRI 3. But the patient is a more than 45-year-old, has a significant history in with the risk of more than 3. So you actually check the preoperative NT-proBNP levels and it is normal. Say how will you evaluate this patient is, because the patient's effort tolerance is more than 4 and other investigations has been normal, you need not evaluate further. Since it's a time sensitive surgery because of a tumor, you can actually go ahead with the surgery and do the surgery with the increased risk of MIS. In the post-operative period, you have to do a serial troponin levels and find out if the patient is landing up in a myocardial injury following a non-cardiac surgery. Suppose, say if this patient's effort tolerance is not known, the patient has a OA, not able to do exercise, then what we would have done is we would have subjected this patient to a stress testing. So this is an AHA guideline and this is the Canadian guidelines. This emergency surgery, as first I have said, the patient on case scenario 1, you proceed to the surgery with risk stratification. In case scenario 2, we have seen an example of significant arrhythmia. We have postponed the planned surgery. See, any acute coronary syndrome, any decompensated heart failure, any significant arrhythmia, and severe valvular heart disease. If you are able to postpone the elective case, first postpone, evaluate, and then do a guideline-directed therapy, and then post for the non-cardiac surgery. So here, in the third example, we have seen the risk of perioperative death or MI with an RCRI. In that, the patient had a score of 3. If the patient had less than 1, I would have proceeded to the surgery immediately. But the patient had a score of 3. Then I moved to step 4 to assess the functional capacity. The functional capacity was more than 4. So no need to evaluate further. You can actually subject the patient to non-cardiac surgery with the increased risk. That is all. Suppose if the patient's effort tolerance to me is not known, this patient has an RCRI of 3. If I'm going to do a perioperative stress testing like dobutamine stress echo or doypyramidamole stress echo, if there is any abnormality which is found, since it's a time sensitive surgery, we have to discuss among experts to find out what is the best solution for that patient. So this is the AHA guidelines, which is there for algorithm for non-cardiac surgery. And this is the Canadian Society guidelines. In this, the Canadian Society guidelines does not actually believe in doing a perioperative exercise stress testing, and also doesn't and also it considers the perioperative role of preoperative NT-proBNP and BNP. In this, again, if the patient undergoes an emergency surgery, you can actually proceed with risk stratification. If it is urgent, if the surgery is urgent, you can actually do investigations which are pertaining to that particular patient, risk stratify, and then take. But if it's a time-sensitive surgery or elective surgery, you see for the age, RCRI, and significant cardiac disease. If the surgery can be postponed, it can be postponed. And there is also a mention about post-operative troponin monitoring. In this case, if the risk is high, you measure the preoperative NT-proBNP or BNP. If the BNP is less than 92 nanograms per liter or NT-proBNP is less than 300 nanogram per liter, no postoperative troponin monitoring is necessary. You can actually proceed to surgery, and then you can actually see if it is more than 92, if it is more than 300, then you have to daily monitor troponin for 72 hours and obtain an ECG which may suggest a postoperative arrhythmia which has occurred. In summary, in any patient who is coming to you for a non-cardiac surgery, decide the perioperative strategies in a patient-specific manner, as I have cited in the case scenarios. And as I've seen many of our colleagues asking for a cardiologist for a fitness for surgery. This aches my heart. Never ask a cardiologist or a neurologist a fitness for surgery. It is always their risk stratification which is needed for surgery. Before subjecting a patient, any cardiac patient, to a non-cardiac surgery, you always get an informed high risk consent. Follow the appropriate guidelines for improved perioperative outcome of the patient. And these are the guidelines from which I have taken my topic from. So JAMA article and 2020 AC and AHA guidelines. It has been very nicely covered in Miller 9th edition. So any of us can, if you want, you can actually go through only 9th edition Miller rather than going through all these references. Thank you.
Thank you, Guru Sandhya, for a wonderful presentation, nutshell presentation. Now, Sarvabhinadri Madam, you can carry on the discussion.
Thank you, Dr. Guru Sandhya, for a wonderful presentation regarding the assessment. There are lots of questions. Most of them are regarding the intraoperative management, but we'll try to ask a few questions. what is the role of dual antiplatelet therapy in spine surgery? Patients who are posted for spine surgery, if they are on dual antiplatelet, what is your take for that?
Ma'am, it actually depends upon when the patient has got MI. As I said, if it is a non-elective surgery following an MI, it can be postponed up to 2 months. If the patient is posted for spine surgery, then you can stop clopidogrel, continue aspirin in the perioperative period, follow all precautionary measures which we would follow as per a cardiac patient, continue clopidogrel in the postoperative period. Discontinuing aspirin has been advised only for surgeries like TURP and closed cavity surgeries and neurosurgery.
Okay. What is the risk of persistent intraoperative hypertension? And another question of persistent tachycardia. These are all anyway intraoperative.
Intraoperative tachycardia and persistent hypertension both have been associated with increased perioperative MACE. But or preoperative blood pressure of 180 or 110, 190, 110, if you stop the surgery from happening, the risk of there is no compelling evidence to say that you have to defer the surgery based on 190, 110. If it's a non-cardiac surgery and if the blood pressure can be controlled in the perioperative period, you can very well go ahead depending upon the risk of the non-cardiac surgery. Say if it's Whipple's or so and the pressure is continuously high for 1 hour, then you can actually think of mitigating the risk with effective hypertension control and then take up. But if it's a hernia surgery or any cystoscopy, you can go ahead with the surgery because the surgery itself carries very low risk of MACE.
Yeah. And there's a patient with cerebral aneurysm posted for repair. His BP has been persistently 160/100. The neurosurgeon insists on not reducing the BP. So
obviously, because you aim for, in case of an SAH, you aim for a triple H therapy. That is what you do it in the perioperative period to maintain the blood pressure ahead of an aneurysm. So that is how they, you can actually give them on nimodipine if the patient has got any significant vasospasm, but then they would actually demand a BP such high to maintain, actually we would use noradrenaline to maintain BP in the postoperative period in an SAH. That is not wrong.
Okay.
Madam, I want to add some more regarding this question.
Okay, sir.
And the maintaining of hypertension in the intraoperative period for aneurysm is mainly to avoid delayed neurological ischemic disease.
Ischemic changes.
That is DNID, they will say. But if you look into the cause for the DNID, it is mainly due to the disturbance of autoregulation and also microvascular thrombi. But in recently published 2019 anesthesiology, there is one article. They have extensively done a retrospective cohort analysis and they found that there is no relation between hypertension and hypertension with the delayed neurological ischemic heart disease. But there is a definite correlation between hypocarbia and delayed neurological ischemic heart disease.
Sir, if I may add, we had two such patients, sir, post cerebral aneurysm clipping. We had one patient for whom the BP was 140 and the patient developed neurological deficit. Once when we increased the BP to 180, the patient's neurological deficit vanished in just 5 minutes, sir. Like,
it's a controversial topic.
Yes, sir. It's a waxing and waning, which we have seen in the perioperative period. But
you cannot say this level of blood pressure
BP,
maintain because it varies between the patients.
Sir, rest of the questions, shall I take it on personal chat?
Any other interesting questions you can ask?
The role of subarachnoid block in patients with moderate aortic stenosis.
Ma'am, moderate aortic stenosis, yeah, some of my senior consultants I have seen them doing even that is controversial. Some of my senior consultants I've seen them doing start on a phenylephrine or a noradrenaline infusion and then they would give a low dose spinal anesthesia. It actually depends upon the individual experience and how comfortable are you with that particular procedure.
You can consider in severe it is contraindicated. Yeah, depends upon the patient and the anesthetist.
Yes.
And okay, rest of the questions I think you can take on. Some questions
I'll take it,
been covered in your talk.
Okay, okay.
Presentation. I now take the privilege of introducing Dr. Ranjit Karthikeyan. He is the HOD of Cardiac Anesthesia, Sri Ramachandra Medical University, and he has delivered around 200 lectures and has got around 52 publications in his name. And he is the section editor of Annals of Cardiac Surgery, and he is also the founder of RA Online, which I think every one of us are aware of, and it is a successful project. We have privilege in welcoming you to our forum, sir. Welcome you, sir. Over to Dr. Ranjit Karthikeyan.
Good morning, one and all. First of all, I want to thank Professor Edward for giving this opportunity, such an excellent initiative. I also want to thank all the team members involved in this. Without wasting much time, because already the topic covered by Dr. Guru Sandhya was too big and too huge. Now we are going for congenital heart disease, which is going to be another big topic. But only one thing I will tell you is anesthesia congenital heart disease by cardiac anesthetist is totally different from non-cardiac anesthetist. Okay. With this introduction, let us go into the topic. I will just summarize at the end why I said this statement. Okay. You can share the screen, sir. Thank you.
Shilpa.
Hi all, welcome to Raw Online. Today we are going to deal with one interesting topic that will test the anesthesiologist with anatomy, physiology and pharmacological intervention. Not only that, your technical skills also will be put into questions. Cannulating a child with pulmonary hypertensive crisis or a cyanotic spell is not going to be easy. That is congenital heart disease for you. In the next 45 minutes, I will be talking about a brief introduction of congenital heart disease, then deal with them individually. What are the preoperative imaging modality which will you do, therapeutic concerns in the intraoperative period, and before winding up, I will give a small brief account about infective endocarditis and how you balance the circulation by altering your pulmonary vascular resistance and systemic vascular resistance. Before 1980s, you can see the mortality from congenital heart disease is around 28%. Since the mortality was very high, the children with congenital heart disease progressing to adulthood is very minimal. But after 1990s and early 2000, lot of advancement happened in cardiac surgery and cardiac anesthesia, and you can see the mortality is reduced around 3%. Because of this, the child with congenital heart disease progressing into adulthood drastically increase. The clinical implication of this diagram is you are going to face more and more patients with congenital heart disease coming for non-cardiac surgery. Congenital heart disease has a special liking for number 3. They come for 3 types of surgery. One is cardiac surgery. Either they come for primary repair or come for a redo surgery. Or they might come for non-cardiac surgery or go into a cath lab for a catheter-based intervention. And they can be classified into 3 types based on the lesions. It can be a left to right shunt or a right to left shunt or an obstructive lesion. With regarding to pulmonary blood flow, another 3 types. It can be high, normal or low pulmonary blood flow. And another way to look at congenital heart disease is that the ventricle and gate vessels. You can look at the inflow of the ventricle, outflow of the ventricle or the great vessels relationship. It can be classified into 3 types of categories. The patient with complete correction and who is normal. The patient with partial or palliative surgery. Here, the patient might be off normal or off abnormal or totally non-operated, where you have to look at the pathophysiology of individual congenital heart disease. There are 3 types of categories. The highest categories are severe pulmonary artery hypertension, uncorrected cyanotic congenital heart disease, complex congenital heart disease with residual like heart failure, valve disease or the need for anticoagulation, prior Fontan procedure for single ventricle physiology, malignant arrhythmias. Coming to high risk categories, here the pulmonary artery hypertension is moderate, partially corrected cyanotic disease like a BT shunt done for a cyanotic congenital heart disease, severe systemic ventricular dysfunction where your ejection fraction is going to be less than 35%, severe left heart obstructive lesion. These are all high risk category. Coming to moderate risk, where you place the prosthetic valve or conduit, an intracardiac shunt, moderate left heart obstruction, and moderate systemic ventricular dysfunction. There is highest, high and moderate risk. There is no low risk category. How are you going to assess the perioperative risk in patient with congenital heart disease coming for non-cardiac surgery? This was a risk scoring system which was done by Harvard, which has 9 variables, with each variable having 0, 1 and 2 points. The first variable is the complexity of the diagnosis. A simple ASD has 0 point. A moderate lesion will have 1 point, and severe like a complex tetralogy of Fallot or transposition of gate arteries will have 2 points. Coming to the intervention, when the patient is undergone surgery and fully corrected and there is no residual, it is 0. Corrected with residual, it is 1 point. Only palliative surgery done, it is 2 point. And coming to the ventricular obstruction, when there is no ventricular obstruction, it is 0. When there is obstruction and when the gradient is less than 49 millimeter of mercury, it is 1 point. When the gradient is greater than 50 millimeter of mercury, it is 2 points. Coming to the number of ventricle as well as the position. There are 2 ventricle and left ventricle is a systemic ventricle, which is the usual circulation. It is 0 point. When there is only 1 ventricle, but the left ventricle is a systemic ventricle, that is 1 point. When there is 1 ventricle, but the right ventricle is a systemic ventricle, you have 2 point. Coming to the ventricular dysfunction, if it is mild, it is 0. If it is moderate, it is 1 point. If it is severe dysfunction, it is 2 points. Coming to pulmonary vascular resistance, if it is normal, 0 point. Between 2 and 4, it is 1 point, and greater than 4, it is 2 points. Coming to the saturation of the patient, if it is greater than 90%, it is 0. Between 75 to 90%, it is 1 point, and if it is less than 75%, it is 2 points. Coming to the hematocrit, between 30 to 45%, it is 0. If the hematocrit is between 25 to 30 or between 45 to 65%, it is 1 point. That means either the child is anemic or slightly polycythemic, it is 1 point. If it is overtly polycythemic, that is greater than 65%, it is going to be 2 points. Coming to arrhythmias, there is no arrhythmias, it is 0 point. Atrial level arrhythmias, it is 1 point. Ventricular level arrhythmias, it is 2 points. Coming to number of medication which patient is receiving, if it is 1, the point is 0. If the number of medication is 2, the points is 1. And if the medication is going to be greater than 3, it is going to be 2 points. How will you assess the risk with this scoring system? If it is between 0 to 6 point, the risk is minimal. If it is between 6 to 13 point, the risk is moderate. If it is between 14 to 20 point, the patient is going to fall in the high risk category. This is how you risk satisfy the patient with congenital disease coming for non-cardiac surgery. Now coming into individual lesions. The most common congenital heart disease, left to right shunt, that is atrial septal defect. Here you have 4 types of ASD. The most common type is the ostium secundum ASD, which is a defect in the middle of the atrial septum. The next type is going to be the ostium primum ASD. Here you can see the defect in the lower part of the atrial septum. The third one is called the sinus venosus ASD, where your SVC or the IVC blood goes via ASD into the left atrium rather going into the right atrium. Here you can see the SVC blood going via ASD into the left atrium. And the fourth type is called the coronary sinus ASD, where the coronary sinus blood goes into the LA. These are the 4 types of ASD. What is the point in knowing this classification? Because each type of ASD will have some peculiar feature. For example, if it is an osteoprimum ASD, it is more common in Down syndrome and they are prone for hypertensive crisis. If it is a sinus venosus ASD, they are prone for little bit desaturation because your venous blood is bypass the right circulation. Ostium secundum, if it is has a good rim, you can use a device to close the ostium secundum ASD. And coronary sinus, again the coronary sinus can be dilated or you can expect a little bit of desaturation. And whenever ASD is there, you should not always think you do surgery. Nowadays, ostium secundum ASD, a lot of people are going device closure. This is the double umbrella device which is used for device closure of ASD. You can see the two umbrella device. One will be inflated on the side of atrium, the another one will be inflated on the side of left atrium. Both sides of the septum where the ASD is there will be closed. Coming to the anatomy and physiology, it is basically a left to right shunt. Blood from the left atrium goes into the right atrium because left atrial pressure is slightly higher than the right atrium. What are the potential issues? Small and moderate size ASD is usually well tolerated. There will be no issue in the perioperative period. But if the defect is too large, it might lead to arrhythmias, exercise intolerance and pulmonary hypertension. This pulmonary hypertension is usually common when the patient with ASD goes into adulthood. Atrial fibrillation in long-standing ASD, and there is a risk of paradoxical embolism. What is this paradoxical embolism? If a hair is injected into the venous system, it goes into the right atrium, bypass the right circulation and through the ASD goes into the left atrium and goes into the systemic circulation. That is paradoxical embolism. Specific anesthesia management is you have to keep the IV line free of air bubble. You should de-air the intravenous line properly. That will be one of the specific anesthesia management for atrial septal defect. Coming to the cardiac grid, repaired, it is almost everything is normal. If it is an unrepaired ASD or a residual left right shunt is there, you have to maintain a slightly higher preload and PVR should be slightly high and SVR should be low. These two things you should do to reduce the left to right shunt, and the heart rate and contractility should be normal. Coming to the next common congenital heart disease, which is ventricular septal defect. It is slightly more complex than atrial septal defect, and here the left to right shunt occurs at the ventricular level and it is usually associated with some other anomalies. It classified based on the anatomy, size of the VSD and proximity to the great vessel. Looking at the anatomy, most of the VSD arises at the membranous part. This ventricular septum has two parts, membranous part and the muscular part. Most of the VSD arises from the membranous septum. And other 20% arises on the muscular part, which is called the muscular VSD. Sometimes they can be a multiple small VSD, which is called the Swiss cheese defect. This is the anatomy part. Another way to look at the anatomy, whether the VSD arises at the outlet part or the inlet part. The outlet VSDs are called supracrystal and the inlet VSD are called infracrystal. That is another way to look at the anatomy. Based on the great vessels, it can be below the pulmonary artery or below the aorta, where it is called the subpulmonic VSD or the subaortic VSD. Based on the size, you can classify as restrictive, moderate restrictive, non-restrictive or Eisenmenger VSD. What is this restrictive VSD? Here the shunt is going to be very small. The VSD is going to be small. So the blood going from the left ventricle to the right ventricle is restricted. The QP/QS might be the ratio of 1, but the pulmonary artery pressure will be 1/3 of the systolic pressure. In moderately restrictive VSD, the shunt is moderate and your QP might be slightly larger than the systemic, that your pulmonary blood flow will be slightly more than the systemic blood flow, and here the PA pressure will be 2/3 of your systolic pressure. In non-restrictive VSD, the VSD is really big and the pulmonary blood flow will be twice that of your systemic blood flow, and here the pulmonary artery pressure will be almost equal to the systolic pressure. And coming to Eisenmenger, where your right ventricular pressure is more than the left ventricular pressure, and the blood from the right ventricle goes into the left ventricle, that means the reversal of shunt has happened. Here, your pulmonary blood flow will be reduced because there is increased pulmonary vascular resistance and blood does not goes into the pulmonary circulation, but the PA pressure will be very high, suprasystemic, due to your increased pulmonary vascular resistance. And like ASD, here also a lot of people are using device closure. Here again you can see the Dunbar-Umbrella defects. This is the right ventricular side and this is the left ventricular side. Both will be inflated and your VSD is sealed. Coming to the anatomy, it is basically a left to right shunt and it is associated with other anomalies. If it is an unrepaired VSD, small to moderate size defect, there is a risk of endocarditis due to increased flow. If it is below the pulmonary valve, they are prone for subpulmonary obstruction. If it is below the aortic valve, subaortic restriction. And some people are prone for aortic regurgitation due to the Venturi effect across the aortic valve by the VSD. Large defect, there is a risk of pulmonary hypertension and right ventricular failure. Whenever there is going to be pulmonary hypertension, your right ventricle is going to be under strain. If it is repaired, the conduction system can usually passes in the membranous part of the system. They are bound to get damaged when you do a VSD closure. Complete heart block can develop in some patient. Even if you close the VSD, there is a chance of pulmonary hypertension persisting in the postoperative period, and the patient are prone for arrhythmia. So you have to remember that. So your anesthetic management is based on such a way you reduce your left to right shunt and maintain the pulmonary blood flow if your pulmonary vascular resistance is very high and there is a reversal of shunt. And always remember, when there is an increased pulmonary blood flow, they are prone for post-operative pulmonary infection. If patient develop complete heart block and you have put a pacemaker, you should know how to manage a pacemaker. Coming to the cardiac grid, repaired, almost everything is normal except that to maintain an increased preload. In unrepaired, your preload should be high. Again, your PVR should be slightly high and your SVR should be low to reduce the left to right shunt, and you have to maintain your heart rate and contractility. Now, let us look at the most common cyanotic congenital heart disease, which is tetralogy of Fallot. As the name indicates, it has 4 major components. The first and foremost is infundibular pulmonary stenosis. The infundibulum is just below the pulmonary valve, and here you can see the infundibulum, right ventricle is, infundibulum is narrowed. That is the first component of tetralogy of Fallot. The second one is, because of the obstruction here, the right ventricle hypertrophies and try to push the blood from the right ventricle into the pulmonary circulation. So, the second component is going to be right ventricular hypertrophy. And third one is overriding of aorta. What is this overriding? You can see the blood from the left ventricle as well as the blood from the right ventricle go into aorta, and there is a mixturing happening. This is the third component, overriding of aorta. Normally, there is going to be more than 40% overriding of aorta. And the fourth component is the ventricular septal defect. Your right ventricular pressure is going to be high and the blood from the right ventricle goes via the ventricular septal defect into the left ventricle. Basically, it is a right to left shunt which causes cyanosis. These are the 4 components of the tetralogy of Fallot. Usually, tetralogy of Fallot, we go with an intracardiac repair where you place a large ventriculotomy across the right ventricular outflow tract. Here you can see the right ventricular outflow tract is be open and the muscle mass which is obstructing the right ventricular outflow tract will be resected. Then you can see a patch is used to close the VSD. You can see the patch here. Once patch is closed, the ventriculotomy which is open is closed with the large pericardial patch. Here you can see the patch which is used to close the ventriculotomy incision. The patch is placed over the incision and here you can see the large patch across the right ventricular outflow tract. This is intracardiac repair. Basically, you resect the muscle mass across the right ventricular outflow tract and close the VSD, then place the patch over the outflow tract. That is intracardiac repair. Some patients you can't do an intracardiac repair or might be in a newborn period where you do what is called the BT shunt, blood lock toxic shunt. Here you can see the shunt. This is the shunt, and this clamp is placed on the pulmonary artery and this clamp is on the subclavian artery. Blood lock toxic shunt is nothing but a shunt between the subclavian and the pulmonary artery. You get the systemic blood flow into the pulmonary circulation. Here you can see the shunt is being anastomosed to the pulmonary artery side. The shunt is being placed here, and once the anastomosis is done on both sides, the clamp will be released and the systemic blood flow will go into the pulmonary artery. That is PT shunt. Once you do the intracardiac repair, you should not assume that everything is normal, because it is a complex surgery. In the post-operative period, you might have lot of problems. So, whenever you do a echo on imaging modality, you have to look at the adequacy of the repair. Here you can see a conduit is being narrowed. It is like same pulmonary stenosis which is in the pre-operative period, or the patch across the right ventricular flow may not hold. It is like not a normal pulmonary valve. So, the blood might regurgitate, pulmonary regurgitation develop, and here you can see the right ventricle is almost double of the left ventricle, or the patch might become aneurysmal, or the VSD which you close might develop a residual leak and there might be a residual VSD. So, once surgery is done, you should not think everything is normal. The most important thing in the preoperative imaging modality, you should look for the adequacy of the repair. Coming to maintaining the patient, it has 4 components: pulmonary stenosis, infundibulum pulmonary stenosis. You have to mention infundibulum because it is a muscle spasm and lot of muscle and right ventricular outflow tract causing obstruction, right ventricular hypertrophy, overriding of aorta, and there is going to be a right to left shunt across the VSD which causes cyanosis. Unrepaired, unless there is lot of pulmonary collaterals, patient may not reach the adulthood and mean age of death is around 25 years. In palliated, where you have done a shunt between systemic artery, subclavian and the pulmonary artery, sometime if the shunt is too large, it might lead to left ventricular volume overload or pulmonary hypertension. If the shunt is too small, it might again lead to cyanosis within 2 or 3 months. If intracardiac repair done, you might damage the conduction system which might lead to sinus and AV node dysfunction. Always there is a chance of dysarrhythmia, and right ventricular failure can develop from chronic pulmonary insufficiency or persistent pulmonary hypertension from a previously done shunt, residual VSD or pulmonary regurgitation. Apart from that, you might have left ventricular dysfunction or ascending aortic aneurysm. Your goal in the intraoperative period is going to be, you should avoid tachycardia, maintain a slightly higher volume status, and contractility should be minimal. You should do everything to increase the pulmonary blood flow and maintain your systemic vascular resistance. That is going to be a most important goal in patient with cyanotic congenital heart disease. If arrhythmias are there, you should detect and manage it. Similar for heart failure too. If patient is on pacemaker, you should know how to use the pacemaker. Now coming to the most common obstructive lesion, which is the coarctation of aorta. Usually you can see the obstruction just distal to the subclavian artery. Because of this obstruction, your left ventricle is going to undergo a hypertrophy and your forward flow into the lower part of the body is affected. So, your cardiac output is going to be low to the lower part of the body and your left ventricle enlarges to overcome the obstruction. That are the 2 main things of coarctation of aorta. Here you can see the obstruction just distal to the subclavian artery. This is the coarctate segment. This was in a newborn period. The child was intubated. Here you can see the balloon inflated across the coarctation of aorta, and once the balloon is inflated, you can see the flow established. You can see the obstruction is overcome. The child was really sick in the newborn period because there was no forward flow, and we inflated across the coarctation and the child became all right. Coming to the anatomy and physiology, there is left ventricular pressure overload and hypertrophy. Because of this, there can be diastolic dysfunction, and as the obstruction is there, aortic branch collaterals will be developed, which can lead to risk of bleeding if thoracic surgery is planned. Most of the coarctations are associated with bicuspid aortic valve, which might lead to aortic stenosis or aortic regurgitation at a later stage. And patient with coarctation of aorta have an endothelial dysfunction, which is a diffuse aortopathy, which can lead to premature coronary artery disease, aneurysm of ascending aorta and descending aorta, because your wall is deranged. And most important thing is 10% of the patient with coarctations may be associated with intracranial aneurysm. Apart from that, most of the patient with coarctation will have severe systemic hypertension, and there will be a gradient between the upper and the lower limb. If subclavian angioplasty or subclavian flap is put over the coarctation, there can be inaccurate blood pressure, particularly in the left arm. Sometimes, even if you correct the coarctation, chance of hypertension persisting into the postoperative period is always there. Your goal is going to be avoid tachycardia and hypotension. Now, moving into complex congenital heart disease. Here, the first and foremost is going to be a transposition of great arteries. Here, normally, pulmonary artery comes from the right ventricle and the aorta comes from the left ventricle. Here, there is a transposition of great artery. Your aorta comes from the right ventricle and pulmonary artery comes from the left ventricle. So, what you are going to do? You have to switch this aorta to the left ventricle and pulmonary artery to the right ventricle. How we are going to do this? You have to take this part of coronary artery along with the aorta and shift it to the left ventricle. Here you can see the segment aorta is transected, and this coronary artery button will be removed from the vessel which is coming from the right ventricle and shifted to the aorta which is being implanted on the left ventricle. Then the pulmonary artery will be anastomosed. Here you can see the aorta is being cut open. You transect the aorta which is coming from the right ventricle. Here you can see the aorta is being transected. Then the coronary, this is all the coronary button which is coming from the aorta which is coming from the right ventricle and being anastomosed into the neo-aorta. Here you can see the coronary button anastomosed there. Coronary button anastomosed to the neo-aorta. And this is the two pulmonary artery, right pulmonary artery and left pulmonary artery, and the transected pulmonary artery which is coming from the left ventricle is anastomosed to the neo-pulmonary artery. Here you can see the pulmonary artery being anastomosed to the new one. Sometimes you may not be able to switch the great arteries. Okay, you can't switch the pulmonary and the aorta. In that case, what you can do is you can switch the atrium. Right and left atrium can be switched, which is called the atrial switch surgery, which is done by Mustard or Senning. Here you create a intra-atrial baffle so that your pulmonary venous blood goes into the tricuspid valve. Okay, your circulation will be in such a way: right atrium, right ventricle, aorta, left atrium, left ventricle, pulmonary artery. Now coming to the physiology. Here the pulmonary artery arises from the left ventricle, aorta arises from the right ventricle. It is going to be associated with variety of lesion. You need some left to right shunt for the survival to happen. It can be associated with right ventricular obstruction like pulmonary stenosis or a left ventricular obstruction like coarctation of aorta, and there can be an abnormal coronary artery anatomy also. If a Senning surgery is done, your atrial dysarrhythmia or sinus node dysfunction can be common because you are meddling around the right atrial conduction system. Systemic ventricular dysfunction happen because your right ventricle is going to be the systemic ventricle, and they can be a residual atrial or a ventricular level shunt. If an arterial switch is done, you have implanted such a small coronary into the neo-aorta. So, there can be chances of myocardial ischemia due to occluded coronary arteries, or sometimes endothelial dysfunction can happen. And there is also a chance of ascending aortic aneurysm. Here, your goal is to maintain the pulmonary blood flow, manage the arrhythmias, and manage your heart failure. If an arterial switch is done, you should have a detailed preoperative evaluation with mainly you have to assess your coronary anatomies by some imaging modality. Now coming to congenital corrected transposition of gate arteries, here you can see the right atrium goes into left ventricle and the left ventricle pumps the blood into the pulmonary artery and it goes into the branch pulmonary arteries. And you have the left atrium going into the right ventricle and right ventricle pumps the blood into aorta. So, your left ventricle becomes the pulmonary ventricle and right ventricle becomes the systemic ventricle. This is congenitally corrected transposition of gate artery. Here, the left ventricle is subpulmonic ventricle and right ventricle is a systemic ventricle. If it is unrepaired, complete heart block can happen. Heart block is a very common entity with congenital corrected transposition of gate arteries. You can have arrhythmias, and right ventricle being the systemic ventricle is bound to fail, and you can have systemic AV valve regurgitation. Although it is repaired, all the complication, all the issues are the same whether it is repaired or unrepaired. Here the specific anesthetic management includes, once you put a pacemaker, you should know how to manage a pacemaker, and source for external pacing should be available, particularly when the patient develops a heart block, and you have to manage your arrhythmia and heart failure. Now coming into the more complex physiology, that is single ventricle. Normally, blood from the venous circulation goes into the right side of the heart. From the right side of the heart, it goes to the lung, get oxygenated and go to the left side of the heart, and through the aorta, it goes into the systemic circulation, and the saturation will be around 95 to 100%. This is the normal circulation. Now, let us assume there is only one ventricle. Okay, here instead of two ventricle, we have only one ventricle. What happens? The blood from the systemic circulation goes into the atrium. From there, it goes into the ventricle, and depending upon how much blood goes into the pulmonary circulation or how much blood goes into the systemic circulation, you will know whether the patient is going to be either hypoxic or your cardiac output is going to be affected. And you always, there will be a slightly little lower saturation. Let us look at the first scenario. You might have an unobstructed systemic circulation. The blood comes into the single ventricle, get mixed and goes into the systemic circulation. The pulmonary circulation is restricted. Here you can see a little bit pulmonary stenosis. So, the child is going to be cyanotic, but what happens is the systemic cardiac output is well maintained. Here you can allow the child to go for 3 or 6 months or 1 year, wait, and then you can do an appropriate intervention. That is the first scenario you face: unobstructed systemic flow and slightly decreased pulmonary blood flow. Coming to a second scenario, you have an unobstructed systemic flow, but the pulmonary blood flow is more than your systemic blood flow. Okay, here you can see the saturation is going to be slightly higher because you have an unobstructed pulmonary blood flow. The problem is pulmonary blood flow to be high, the PVR becomes high and the child cannot undergo an intervention at a later stage. So, you have to restrict the pulmonary blood flow and increase the systemic blood flow more than your pulmonary blood flow. What you are going to do to achieve it? You place a band across the pulmonary artery to restrict the pulmonary blood flow. The patient might become slightly cyanotic, but at a later stage, the PVR doesn't go up and you can do an palliative surgery at a later stage. So, in this case, whenever there is an unobstructed systemic flow, but the pulmonary blood flow is more than the systemic, you have to go and band the pulmonary artery. The third scenario is unobstructed systemic flow. The systemic flow will be adequate, but the pulmonary blood flow is too less. The oxygen is going to be too less and the patient is going to be severely cyanotic. Here you have to do something to increase the pulmonary blood flow. So you do what is called a BT shunt. Place a shunt between the systemic artery to the pulmonary blood and increase your oxygenation. Now, so far we are looking at the three scenario where is unobstructed systemic flow. Whenever there is an obstructed systemic flow, like an hyperplastic left ventricle, your cardiac output is not there, and unless you intervene in your newborn period, the child won't survive. Here you have to do a complex procedure, what is called a Norwood, where you create the left ventricle, you create a new aorta and put a shunt from the new aorta to the lung. You create a shunt as well as you create a systemic circulation. That is complex Norwood procedure. In stage 1, where you have an unobstructed systemic flow with a balanced pulmonary blood flow, you delay the surgery till child is 1 year of age. If there is an insufficient pulmonary blood flow, you go for a BT shunt, or if there is an excessive pulmonary blood flow, you do a band and restrict the pulmonary blood flow. If it is obstructed systemic flow, you go for a complex Norwood procedure. In stage 2, you do what is called a Glenn procedure, where you divert the blood from the SVC, upper part of the body, to the pulmonary circulation, and you do what is called a completion Fortin, which is stage 3, where you divert the entire venous system, both from the SVC and IVC to the pulmonary circulation, which is usually done at 2 to 3 years of age. You have a left ventricle which is hyperplastic. Here in the upper part, this is ASD and this is the PDA. So blood from this part, you have an hyperplastic ventricle. So the blood has to go to the right side to the ASD, mix at the upper part, then come via PDA and go to the systemic circulation. This is a gross rough physiology of how the circulation will be maintained in a univentricular heart. Now coming to the anatomy and physiology, you have double inlet atrioventricular connection, absence of one atrioventricular connection, and there is only one single developed ventricle. There is only one ventricle. Your inlet might be 2, outlet might be 2, but the ventricle will be always 1. In unrepaired, usually survival won't be possible, but lot of case reports where patient goes into adulthood are there. In those cases, you might have dysarrhythmias, congestive cardiac failure, bidirectional shunting, cyanosis and pulmonary hypertension. In repair, it can be either a BT shunt, Glenn or a Fontaine. Here you can have dysarrhythmias, heart failure, hepatic dysfunction, thromboembolic phenomenon, and also restrictive lung disease. Your specific anesthesia management is going to be managing the dysarrhythmia, maintain pulmonary blood flow. Again, if repair is done, again you have to maintain dysarrhythmia, maintain low PVR to increase your pulmonary blood flow, maintain adequate preload and replace coagulation factors. This is an advertisement which was given for a zoo and aquarium in Pittsburgh. So if you look at the image properly, what you can see is a tree and a bird flying. But if you look little bit zoom, you can see a lion and gorilla facing each other. And if you look at the tree properly, lot of fishes, frogs and other sea animals are there. So that is the reason they use this image for the zoo and the aquarium. But in the first stage, when you looked at it, you can see only the tree. What the mind doesn't know, the eye never see. That is very true for the imaging modality in the preoperative period. Unless you know what to look for, you can't definitely see, particularly in complex congenital heart disease. And your first imaging modality is going to be your echocardiogram, which is required for the diagnosis. Here you get the intracardiac anatomy, your blood flow characteristics and velocity across the obstruction and gradient. Whenever you do an echocardiogram, this is the echocardiogram of the hypoplastic right ventricle. Here you can see the right ventricle is hypoplastic, left ventricle is okay, heart is moving relatively okay. Whenever you get an echocardiogram, immediately you should have an imaging, you should draw that picture into your mind. See, this is a hypoplastic right ventricle. If right ventricle is hypoplastic, how the circulation is going to be? Immediately you should know there will be an ASD, there will be a PDA, and your right ventricle is small, the tricuspid is not normal, the pulmonary is atretic, everything you should have a picture immediately into mind. That is the most important goal. I can understand non-cardiac anesthesia also, it is going to be very difficult to have a pictorial understanding, but unless you have this pictorial understanding, the managing the case in the perioperative period is going to be very difficult. Now, MRI, cardiac MRI has become the gold standard, particularly when the diagnosis is becoming more and more complex. It gives an excellent tissue characterization, and the quantification of volume and gradient and the myocardial mass is far better than echocardiogram. Even minute quantities can be estimated with great clarity with MRI, and it can help in the evaluation of outflow conduit as well as adequacy of repair. Here you can see a double inlet left ventricle. Here you can see the right atrium, left atrium blood goes into the left ventricle, and from the left ventricle it goes into the aorta and pulmonary artery. This type of imaging, you can see the right ventricle being hypoplastic. This type of excellent characterization of the volume and tissue you can never happen with echocardiogram. So, MRI has become the gold standard with congenital heart disease. And fountain is nothing but you divert the IVC as well as the FVC blood into the pulmonary artery. Sometimes the conduit pressure can become high. In that case, you fenestrate the fountain and divert little blood flow from the circuit to the left side. In that case, okay, this fenestration, with the MRI, even this fenestration, how much blood is going into the fenestration can be calculated. That is the greatness of MRI. Here you can see the SVC blood going into the left pulmonary artery and the right pulmonary artery. Coming to CT imaging. Usually MRI has taken over, but CT imaging has a role to play in the congenital heart disease, particularly when there is aortopulmonary collateral or AV malformation, evaluation of lung and parenchymal mass in restrictive lung disease. Sometimes intra or extra cardiac mass are better visualized with CT imaging, and in arterial switch or something, you want to look at the coronary artery anomalies. Some patient might progress into adulthood and might have coronary artery disease. In those cases, CT imaging will be a better modality. In short, CT scan can be used whenever you need to assess some vascular structures. Coming to cardiac catheterization, it is usually done when there is a doubt in echocardiogram or other imaging modality. It can be diagnostic or therapeutic. It should be considered whenever you have to establish your PVR, pulmonary vascular resistance. Also testing your pulmonary vascular reactivity to oxygen with various FiO2. For example, what is your PVR with FiO2 of 0.5 and what is your PVR when the FiO2 is 1, pressure gradient and shunt quantification, coronary angiogram. As I said, some patient might progress into adulthood where you have to do a coronary angiogram, and evaluation of extra cardiac vessel like your aortopulmonary collateral artery. Multiple MAPCAs can be there. MAPCAs is nothing but aortopulmonary collateral. You have to identify how many collaterals are there, because before when you go for surgery, you have to either coil embolize those aortopulmonary collateral before patient going into complete cardiac repair. Now coming to the most important period. In the perioperative period, patient are prone for 4 things. One is heart failure, arrhythmias, pulmonary artery hypertension and cyanosis. Let us look at heart failure first. When you have a severe valvular abnormality, either ASAR, MS, MR, unoperated left to right shunt or a partial AV canal septal defect, corrected congenital transposition of great arteries, transposition of great artery after sending atrial switch can lead to heart failure in the post-operative period, tetralogy of Fallot with early era surgery where they open the right ventricle in a large way. it will be a large ventriculotomy, which can lead to failure in the postoperative period, long-standing shunt, or severe PR. This can lead to heart failure, single ventricle physiology, and Fontaine surgery. These are all the various cases which can lead to heart failure in the perioperative period. Predisposing factor, it is going to be prolonged cyanosis, prolonged pressure overload where there is valvular obstruction, volume overload which can occur with aortopulmonary shunt, regurgitation, or a residual shunt, poor myocardial preservation which might lead to heart failure. And when this patient comes for non-cardiac surgery, managing the heart failure is going to be really tough. Large ventricular septal patch due to a large ventriculotomy, large ventricular incision, residual obstruction. It can be left ventricular outflow obstruction as in HOCM, or a right ventricular outflow tract as happens with the conduit across the right ventricle to the pulmonary artery, residual shunt where a VSD patch might leak, arrhythmias, and obesity. Coming to management, here it has to be individualized. The thing which you can do in the perioperative period is restrict fluid and avoid anesthetic agent which causes myocardial depression. Diuretic, inotrope, vasodilators definitely will help in acute management, but usually it is suboptimal because it is a mechanical cause. Unless you do a surgical correction, this heart failure will never improve. If arrhythmias are the cause for heart failure, you can go for cardiac resynchronization therapy, and VAD and ECMO can be used at the last stage, and if nothing works out, only heart transplant can be done. Now coming to the pulmonary artery hypertension, what was reactionary and reversible in the initial left to right shunt later becomes fixed and non-reversible, and reversal of shunt from the right to left side will happen. And you have to understand that right ventricle never tolerates increased pressure overload. So whenever there is pulmonary hypertension, there is going to be right ventricular failure, and reversal of shunt happens, Eisenmenger sets in, and there is going to be hypoxia, cyanosis, and low cardiac output. Whenever there is Eisenmenger, your perioperative mortality is going to be very high, and you have to do non-cardiac surgery only if it is absolutely essential. And how you are going to manage your pulmonary hypertension? You have to give 100% oxygen, hyperventilate the patient, do all the maneuvers to reduce your pulmonary vascular resistance, acidosis, hypoxia, hypercarbia, all should be avoided. Administration of pulmonary vasodilator. Here, nowadays, lot of intravenous pulmonary vasodilators as well as inhaled pulmonary vasodilators have come into picture. So, the pulmonary vascular resistance has to be treated, and as a non-cardiac anesthesiologist, you should be aware how to administer the pulmonary vasodilator. Support your right ventricle either with small dose of dobutamine or milrinone. And most important thing is, don't forget to take care about pain and anxiety. That might precipitate a pulmonary hypertensive crisis. So take care of the pain and anxiety. Coming to arrhythmias, usually the onset of arrhythmias signals hemodynamic decompensation, and it is the most common cause of morbidity and mortality. Here, the investigation, risk assessment, and treatment are different from totally in a normal patient. In a congenital heart disease, it is totally different. And the most bad thing in this is the drug therapy is poorly tolerated. You have a mechanical cause for arrhythmia. Unless you correct that mechanical cause, the patient may not improve. So you have to go for a catheter ablation or a surgical ablation. And here I will mention what are the various common arrhythmias which will happen with various congenital heart disease. Right bundle branch block, RSR pattern, is usually common with tetralogy of Fallot and atrial septal defect. That is after the repair. Left bundle branch block, common after surgery of left ventricular outflow tract obstruction. You will have a white QRS complex. Nodal rhythm or right axis deviation or right ventricular hypertrophy usually happens with atrial switch surgery, either with mustard or Senning. ST wave abnormalities, here you can see ST depression, which can happen with Fontaine circulation. That doesn't mean ischemia, you have to understand that. And WPW syndrome or a pre-excitation syndrome usually happens with Epstein's anomaly and congenitally corrected transposition of gate arteries. And supraventricular tachycardia, SVT and atrial flutter are seen with postoperative atrial switch, postoperative Fontan and tetralogy of Fallot. Atrial fibrillation, here you can see a slow atrial fibrillation and atrial smoke. Atrium is fibrillating. This type of atrial fibrillation, which is the most common rhythm, is seen with mitral valve disease, aortic stenosis, tetralogy of Fallot and palliated single ventricle. And VTAC usually seen after surgery on the right ventricular outflow tract and the left ventricular outflow tract. So, seen with tetralogy of Fallot and aortic stenosis. And bad arrhythmias, whenever you do surgery around the right atrium, sinus node dysfunction happens. It can be with mustard, sending, Fontan, sinus venosus ASD or atriotaxic syndrome. Spontaneous AV block can happen with AV septal defect and congenital corrected transposition of gate artery. Surgically induced AV block, whenever you do a VSD closure around the membranous septum, there are conduction system, so it can induce a AV block. Subaortic, left ventricular outflow tract, left bundle might be damaged, it can lead to an AV block and aortic valve replacement. Coming to management of arrhythmias, the first and foremost, you are going to try antiarrhythmics which may not work, and most important thing is you have to take care of the electrolyte imbalance. And if there is hemodynamic imbalance, you have to go with cardioversion or overdrive pacing. As I said earlier, nothing works out, you have to go for a catheter ablation or a surgical ablation. Now, new generation ICDs which suits congenital heart disease and small kids are available. You have to implant particularly when the arrhythmias are malignant. Pacemaker you do for normal bradyarrhythmias. So, how we are going to tackle the hematological and bleeding issues? Modified and continuous ultrafiltration will help in the controlling the bleeding and reduction of inflammatory mediators. Your blood salvage and reinfusion. Use of antifibrinolytics will help to reduce the blood loss, and you have to monitor the tech to know the correct blood product usage, and you should have a low threshold for factor 7 and PCC if the bleeding is uncontrollable, and you should have a very low threshold for re-exploration. Coming to renal issues, there will be chronic hypoxia. The patient might develop globular abnormality which can affect the renal function. So, what you are going to do? You have to avoid the dehydration. You have to avoid nephrotoxic drugs, minimize the injection of radiocontrast during the imaging studies. You have to follow renoprotective strategy and maintain a high perfusion pressure. Coming to infective endocarditis prophylaxis, it is restricted to highest risk patient and high risk procedures. You have to understand this is 2014 guidelines, and highest risk, who are the highest risk? Congenital heart disease with prosthetic cardiac valve or a prosthetic material used for valve repair, and patient has an history of previous endocarditis. Unrepaired and palliated cyanotic congenital heart disease including surgically constructed palliative shunt and conduit. Completely repaired but prosthetic material is used, and this case you have to give at least first 6 months after the procedure. Repaired congenital heart disease with residual defect at the site or adjacent to the site of a prosthetic patch or a prosthetic device that inhibits endothelialization. These are all the highest risk where you give infective endocarditis prophylaxis. What are high risk procedure? Only two things: dental procedure and a vaginal delivery at the time of rupture. These are all high risk procedure. Coming to the last part, which as an anesthesiologist you play a major role to either increase the pulmonary blood flow or maintain the forward flow, cardiac output. So, you have to know the factors which decreases the pulmonary vascular resistance or increase the pulmonary vascular resistance. Similarly, for systemic vascular resistance, the first and foremost is you are decreasing your pulmonary vascular resistance. You have hypocapnia, and the use of pulmonary vasodilator decreases your pulmonary vascular resistance. What are the factors which increases your pulmonary vascular resistance? Hypoxia, hypercarbia, high hematocrit, positive pressure ventilation, acidosis and alpha adrenergic stimulation. What are the factors which increases your systemic vascular resistance? Sympathetic stimulation, use of vasoconstriction, and hypothermia. And what are the factors which decreases your systemic vascular resistance? Use of systemic vasodilator, your regional anesthesia, spinal and epidural anesthesia, deep general anesthesia, and hyperthermia. These are the factors which decreases your systemic vascular resistance. As an anesthesiologist in the perioperative period, you have to use these 4 things to manage either your pulmonary blood flow or maintain your cardiac output. So to conclude, you have to understand the anatomy of congenital heart disease as well as the physiology behind it. The 4 main therapeutic concerns you have to understand: heart failure, pulmonary artery hypertension, arrhythmias, and cyanosis, and you have to know how to manage them individually. Infective endocarditis prophylaxis. If a left to right shunt is there, air bubble prophylaxis, particularly in atrial septal defect. You have to balance between systemic vascular resistance and pulmonary vascular resistance to maintain the circulation, and don't forget the post-operative period. Thank you.
Thank you, Ranjit. There is one comment in the chat box. It is simply superb.
Sir, sorry for exceeding the time. It's a quite complex subject.
You can start any questions.
Thank you for this elaborative discussion and wonderful animations, sir. There are few questions. One question from Professor Nagasamy, sir. Is RVH present at birth in patients with tetralogy of Fallot? Because in intrauterine period, there is no blood flow.
It will take at least 4 to 6 weeks development. Once in the newborn period, after 4 to 6 weeks only RVH sets in. Okay. So it will take 4 to 6 weeks actually.
And another question, what is the acceptable SpO2 or preferable SpO2 in the perioperative period in a cyanotic child who is coming up for non-cardiac surgery?
That depends upon the anatomy required for cyanosis. Okay, if it is pulmonary atresia or tricuspid atresia, it will be even in 30s, 40s. If it is a tetralogy, it will be 70, 80s. So what you do is you measure the pre-op SpO2. For example, it is 76 in tetralogy. Don't allow another 10% drop. At least if it is 70, don't allow it to stop below 60 or something. In pulmonary atresia or tricuspid atresia, it is going to be very low. It will be around 30, 40. In that case, you can't do anything unless you do an emergency surgery. Whatever is, it is going to be very, very low. You can't low beyond that. Go low beyond that. Okay, but a cutoff should be somewhere between 10% of the pre-op value. That I could say.
Yeah, and the last question, sir, what kind of sedation is preferable in such children if you're going to take them for CT or MRI or cardiac catheterization?
That has to be individualized, ma'am. We have to know further whether it is pulmonary hypertension causing the problem or cyanosis causing the problem. Accordingly, you have to give. You can't have a blanket rule for all patients. Like this patient, I will give this patient. You have to individualize each patient. You have to have a cardiac girdle pain, and you have to manage the anesthetic need for that patient. It's like that. Usually for CT scan, what you can do is small dose of ketamine, whether it is a left to right shunt or right to left shunt, we can give safely, provided the anesthetist know the consequence. It is not the anesthetic drugs which is dangerous. It is the anesthesiologist who know about the anesthesia have to decide. That is the only thing.
And
usually they don't give much trouble.
And the cardiac grid that you have mentioned must be useful in managing such patients.
Yeah,
that's very nice.
Yeah, yes.
Thank you, sir. Thank you for your wonderful lecture. Thank you.
I want to thank all the non-cardiac anesthesiologists here. That's what I said. See, managing a cardiac patient by a cardiac anesthetist is actually easy. I have all resources, everything which is possible in my hand. But non-cardiac anesthetist managing a case without invasive monitoring and other things adds off to all non-cardiac anesthetists. And I thank Edward sir for this excellent opportunity. Thank you.
Thank you, Ranjit. Thank you.
Sure.
The next lecture is going to be by Dr. Divesh Arora. He's a director and HOD of Anesthesia and OT services in Asian Hospital. He had already been to our forum and he had presented the interscalene block some weeks before. He's an NABH assessor also. He's a Green OT assessor and he's a past president of ISA Haryana State Branch. Over to you, sir.
Welcome, Divesh.
Thank you very much for the warm welcome. It has been the second time I'm here first for interscaling block in the month of January. So I thank Dr. Guru Santhia, Dr. Edward Johnson, sir, for having me once again. So today I'll be talking about ultrasound guided blocks for chest wall surgeries. So these are going to be some of my learning objectives. First, we'll have an introduction, and anatomy knowledge is, as you know, is very essential for all these blocks. Then specifically, we'll cover paravertebrals, pecs, serratus anterior, and ESP, which is my favorite block. And then we'll do a literature review as well as summarize everything. So my dear friends, up till 2010, if we actually see regional anesthesia for chest wall surgeries, it was limited to gold standard number 1, that is thoracic epidural, and gold standard number 2, that is thoracic paravertebral block. But over the years, we have realized that epidural technique is no more the gold standard, as published by a famous anesthesiologist of Indian origin, Dr. Narendra Raval, published in RAPM 2012, where he had cited that if you have to cite a epidural, first of all, it will lead to bilateral effects. We have done a right side thoracic surgery and we do not want effects on the left side. Plus, it involves a lot of technical expertise. Not everyone, as a beginner in anesthesia, can do this. Plus, there are risks to the record and adverse effects like hypotension, which we have seen whenever we give a thoracic epidural. But with the better understanding of the anatomy and with availability of ultrasound guidance, since 2011, we have had so many chest wall blocks which have been described for chest wall surgeries. So let's look at the anatomy of the chest wall. We'll start with posterior and come towards anterior region. Posterior chest wall extends from the axillary line, that is the posterior axillary line, to the spinous processes. It is generally supplied by the dorsal rami of the thoracic spinal nerves. Additionally, it also receives branches from the posterior divisions of the lateral cutaneous branches that arise from the intercostal nerves. So coming on to the innervation of the anterolateral chest wall and the axilla, and the famous surgery which we have to understand regional anesthesia technique is the breast surgery. So it is by the branches of the lateral cutaneous branches of the thoracic intercostal nerves, principally T2 to T6 for breast and T2 to T9 for other surgeries. Brachial plexus innervation is also there in the form of medial pectoral nerve, lateral pectoral nerve, long thoracic nerve, which supplies serratus anterior, thoracodorsal nerve, which supplies latissimus dorsi. And if you look at the supply of the axilla, it is by intercostobrachial nerve, branch of T2, and medial cutaneous nerve of the arm, also known as MBCN, which is a branch of brachial plexus. And if we closely observe, certain cervical plexus branches like supraclavicular nerves with medial, intermediate, and lateral also supply the superior portion of the breast. So this is how we can plan analgesia for breast as well as enterolateral and chest wall surgeries. So now coming on to the innervation of the anteromedial chest wall, which is also an important structure. It extends from the midline from sternum till mid-clavicular line. So it is innervated by the anterior cutaneous branches of thoracic intercostal nerves. So the main trunk of the intercostal nerves, after reaching close to the sternum, it divides and gives rise to an anterior cutaneous branch, which has got a medial division as well as a lateral division, so as to take care of the sternal nerve supply as well as supply from sternum till mid-clavicular line. This fact we have to consider when we are planning analgesia for breast surgeries on the medial half of the breast. So my dear friends, what all blocks are available as regional anesthetist for thoracic surgeries? So as I said, the gold standard number 1 was thoracic epidural with its pitfalls. The second gold standard was thoracic paravertebral block. But with the advent of various interfacial plane blocks, we have so many interfacial plane blocks which have been described, particularly for posterior chest wall, ESP, retrolaminar, and midpoint of transverse process to pleura. These are actually paravertebral by proxy. These will also work for anterior chest wall surgeries, although I've classified them as paraspinal, but actually they block the ventral ramus, that means the intercostal nerve, and they can be effective for anterior chest wall surgeries also. Then exclusively for posterolateral chest wall blocks is the rhomboid intercostal plane block or rhomboid intercostal subserratus plane block. And enterolateral, everybody is aware, pecs and serratus anterior. Enteromedial, as you may be aware or you may not be aware, there are two typical blocks, which are pecto-intercostal facial block and transverse thoracic plane block. So I'll be discussing each and every block in detail. So coming on to the second gold standard, as I call it for thoracic surgery, is the thoracic paravertebral block. Let's understand the anatomy. Thoracic paravertebral space is a wedge-shaped space. It has got a medial boundary, which is the vertebral body. Anterolaterally, we have the pleura, and posteriorly, the structure of interest is the superior costotransverse ligament. Medially, it communicates with the epidural space. Laterally, it communicates with the intercostal space. Superiorly, up till cervical epidural space, paravertebral space, sorry, and inferiorly, it reaches up to psoas major. So how do we actually do this block? There are two approaches which have been described in literature. You can image this space in the transverse imaging or in the longitudinal parasagittal imaging. The main target would be to identify superior costotransverse ligament, and anterior to that is the pleura. And in both imaging techniques, we can do an in-plane as well as out-of-plane approach. So I'll discuss the approaches which are normally used by me and tell you the advantages and disadvantages of various approach. The approach which is normally used by majority of the regional anesthetists is the parasagittal imaging of the thoracic paravertebral space, and we use an in-plane approach. So for us to perform this block, the patient can be either in the lateral position as shown in this figure, or in the sitting or in the prone position. As it is a superficial block, my friends, you can realize that we use a high frequency linear probe. Again, parasagittal probe orientation, in-plane approach, caudal to cranial direction, and 20 ml of the drugs, ropivacaine or bupivacaine half strength is sufficient. And the most important sign which we are looking for is the anterior displacement of the pleura or pleural drop, it is called. So let's look at the small video. The needle is going to come from the caudal to cranial direction. You can see the shimmery pleura. My initial test injection is the intertransverse ligament. So it has not pierced the superior costotransverse ligament. I make small adjustments, and then again I try to pierce the superior costotransverse ligament. Again, I am unsuccessful. Now you'll realize suddenly I have pierced the superior costotransverse ligament visibly, and the pleura goes down. So this pleural line going down means that there is an anterior displacement of the pleura or the pleural drop, and rest of the drug can be easily injected. And once completing the block, you can analyze the other spaces, and then you realize the drug would have reached there also. So another approach which we have been doing in our department is the outer plane approach, where instead of coming from caudal to cranial in plane, we come anterior towards the superior costotransverse ligament. We try to pierce it, and we again watch for anterior displacement of pleura or pleural drop, that is called as. Let's have a look at this video. So again, my needle, in this case, outer plane approach, the needle cannot be appreciated. It's the indirect movements which happen through the various muscles which can be appreciated. Now you can see the pleura has dropped and we have completed the block. So coming on to the transverse imaging, a majority of us are doing parasagittal imaging. There are some anesthetists who still prefer to do transverse imaging. And in a review article by a famous anesthesiologist published very recently in 2019, they have cited that transverse imaging should be avoided because as we are coming from a lateral to medial direction, there is a chances of inadvertent intrathecal or epidural spread is possible, as you can easily see in this skeletal diagram. And we are injecting 20 ml of the drug, which is quite close. So there are chances it can track towards 20 ml. Tracking towards epidural space or intrathecal space can lead to a havoc. So that is why my advice, personal advice is please practice parasagittal imaging and try in plane or out of plane. That is up to you. Plus, it is an advanced level block. Start with ESP. Once you are proficient with ESP, then progress towards thoracic paravertebral. So what are the complications and side effects? So I have cited two important articles. First was in 1995 and subsequently in 2017, where they have analyzed the complications of paravertebral block. So the fearful complication is like pleural puncture, which was around 1.1%, and over the years, as performed by experienced anesthesiologists, it has dropped to 0.6%. And pneumothorax frequency is quite less, but these review articles have blocks which are being done by experienced anesthetists. As a beginner, this incidence would be around 5 to 6%. So this is not worth taking a risk. So since we have ESP available, start with ESP and then slowly try to reach towards thoracic paravertebral space. So coming on, starting with the interfacial plane blocks, the first was the PEX, which was described by Rafael Blanco as early as 2011. It's essentially a musculofacial plane block where local anesthetic is deposited between PEC major and PEC minor, and it targets medial and lateral pectoral nerve. Isolated PEX1 has got limited indications. So subsequently in 2012, Blanco and his colleagues described PEX2 block, which is essentially a combination of two blocks, PEX1 and PEX2. PEX2 targets the PEC interfacial space between PEC minor and serratus anterior at the level of third and the fourth rib. And it targets the lateral cutaneous branches of intercostal nerves, long thoracic and thoracodorsal nerve. So let's understand the PEX block technique. It's quite a superficial block. The patient has to be supine, head has to be turned to the opposite side, and arm has to be minimally abducted. Superficial block, so we make use of a high frequency linear probe. Initially, we place the transducer as we would have done it for an infraclavicular block, and then try to move our transducer in the deltopectoral groove with slight medial tilt so as to identify the ribs. The aim is to identify the pec major, minor, axillary artery and vein, and start moving towards axilla over third and fourth ribs. So coming on to the sonoanatomy, this is the third and the fourth rib. The needle is going to come from superomedial to inframedial direction. Initially, we do the PEX2 block between PEC minor and the serratus anterior. We inject 20 ml of the drug, that is 0.375% of ropivacaine or 0.25% of bupivacaine. Then we withdraw the needle and come back again to deposit between PEC major and minor, thereby blocking the medial pectoral and the lateral pectoral nerves. Here the volume used is 10 ml of 0.375% ropivacaine. So this is how we do the block. Now I'll actually trace you with the sonoanatomy in a patient. So initial placement is like a infraclavicular block. Then we start moving the probe in the deltopectoral groove and with a medial tilt. The first rib which comes underneath the axillary artery is the second rib. Subsequently, we come close to the third and the fourth rib. Once we sight the third rib, you will realize another muscle comes into picture. That is the serratus anterior. So this is the site, good site to give PEX2 as well as PEX1 block. So let's have a quick look at the video of this block. This is supromedial. This is inframedial. The needle is going to come from this place. So PEC major, minor, serratus anterior. The first injection is between PEC minor and the serratus anterior, where we actually deposit 20 ml. And while withdrawing, you can complete the block between PEC major and minor. That would be the PEC1 block. So is this block actually effective? There have been a couple of RCTs as well as meta-analysis. I am showing just one of them to save on the time. This was published in Anesthesiology 2019, where they compared PEX block in breast cancer surgery. In compared to control, it was very effective, but in compared to paravertebral block, they stated it is non-inferior. That means it has got good efficacy. So it's a good block to be considered in breast surgeries. So coming on to another block, which was described by Rafael Blanco and colleagues in 2013, that is a serratus anterior plane block. It is a musculofacial plane block again, and it targets almost the similar nerves which were targeted by the PEX2 block. And both superficial as well as deep serratus anterior plane blocks have been described in literature. So how do we actually do it? So for this block to be done, this can be done in supine as well as lateral position. In this pic, I have shown you in a supine position. The patient is placed in a supine position with the arm abducted 90 degrees. So it's a superficial block, so we need a high frequency linear transducer, and it is placed between anterior axillary line and the posterior axillary line. The aim is to identify latissimus dorsi, and we use a Pejunct needle, 8 centimeter, in plane approach, anterior to posterior, and it's a plane block. So we inject around 30 ml of the ropivacaine, 0.375%. So this is the sonoanatomy of the serratus anterior plane block. So needle is going to come from anterior to posterior direction. In this plane, we can identify thoracodorsal artery. So we have to avoid it. we can do either a superficial block or a deep block. Superficial means injecting between latissimus dorsi and serratus anterior. Deep means injecting between serratus anterior and the rib. So here's a small video. This side is right side of the screen is anterior, left side of the screen is posterior, and our needle will be coming from anterior side towards posterior side. You can see the pulsatile thoracodorsal artery, which I'm trying to avoid. This is a plain block, my dear friends. So you have to deposit around 30 ml and keep moving the needle in the length of the local anesthetic so created so as to completely distend this space. In case you have any doubt, you can do a deep block also. So which block should we prefer, superficial or deep? Initially, when Rafael Blanco described, he said superficial gives you a wide coverage, whereas deep block gives you a less coverage. But over the years, RCTs have been designed, which have found that there is no difference between superficial and deep. So you can continue doing either of them depending on your expertise. So is it effective? Yes, my dear friends. If we actually compare with control groups, it's effective for breast and thoracic surgery. And on the basis of 5 trials which were included in this meta-analysis, it was not appreciably different from paravertebral block. So both these blocks compare to our second gold standard, that is the paravertebral block. So coming on to my favorite blocks, and this is the most well-described block and most common one these days, I would say, and it is the flavor block for all the regional anesthetists. It was first described by Forero in 2016 for thoracic areas, and now it is available for cervical, lumbar, as well as sacral areas also. So it's essentially a musculofacial plane block where LA is deposited deep to erectospinal plane muscle, and it targets the ipsilateral spinal nerves. So there has been a lot of confusion regarding the mechanism of action. Initial cadaveric studies suggested it blocks only ventral rami very selectively, and blocks dorsal rami in almost each and every case. So our mind raises a question that if it's not able to block ventral rami, how is it effective for breast surgeries? And in my personal experience, I've been using this block since 2017 for breast surgeries, and it is very effective. Even for our previous head of the department of anesthesia, she had cancer surgery. We gave it to her and she was pain-free for next 24 hours. So various studies have been devised, MRI studies and clinical studies, where they have actually found that it is effective for ventral rami block. So let's understand the mechanism of action. See, once we inject our local anesthetic underneath erectospinal muscle, it diffuses in the craniocaudal direction, which we all know. But it certainly gains entry towards the paravertebral space. Some local anesthetic also diffuses towards the epidural space, and also there is a lateral space. So the mechanism which have been explained in recently by MRI studies in Canadian Journal of Anesthesia 2020, they have found that the pleura exerts a negative pressure once the patient wakes up. So certainly the drug gets pulled towards the paravertebral space, thereby blocking the ventral rami. And plus what happens once the patient wakes up, there is active erectospinal muscle contractions which are happening. So these also tend to push the local anesthetic towards the paravertebral space. So in my clinical practice from the very beginning, we have been using this block towards the end of the surgery. That is why we're getting very good effects, because the patient wakes up immediately, then we get a negative pleural pressure, and then we get a positive contractions of the erectospinal muscle. So how do we actually do it? It's almost similar to paravertebral block, the positioning of the patient. You can do in either lateral, sitting on the prone position, superficial block, so high frequency linear transducer is good enough, parasagittal orientation, in plane approach, caudal to cranial direction. Again, we inject the same volumes of the drug, around 20 ml of ropivacaine, 0.375%. So this is how the sonoanatomy would look like once you are actually at the transverse process. Transverse process has got a squared appearance. And if you turn the probe slightly outwards, then you get to see the superior costotransverse ligament. So the needle will come from caudal to cranial direction, inject up over the surface of transverse process, thereby lifting the erectospinal plane muscle. So I'll first of all tell you how to count the ribs. Traditionally, if we use the palpatory method, you'll realize that the thoracic spine overlies on the next spinous process. So for example, if we actually look at this, if I palpate this spinous process, this will correspond to the transverse process of the lower thoracic vertebra. So this fact has to be kept in mind whenever you use a palpatory method. So in order to circumvent this problem, USG can be used to count the ribs as well. So this has been a recently published article in RAPM in 2021, where they have actually showed how to count the ribs using ultrasonographically. So we can use a linear probe, place the probe close to the nape of the neck. So the first vertebra which comes into picture is our first rib. Sorry, the first rib which the first bony shadow which comes into the picture is the first rib. How do we confirm that it is the first rib? You can then move the probe a little laterally and then it will disappear, because first rib is very short and it articulates uh, anteriorly. So let me show you how do we actually do it. So the first rib comes into picture. Okay. Subsequently, as we move downward, you will be seeing the next rib, which is the second rib. Then as we move further down, we get to see the third rib. And this is how we can start counting our ribs and then trace our probe towards the medial direction to count the respective transverse processes. So I'll show you the sonoanatomy of the erector spinae block, how actually we do it. So we do not start from the midline. We actually start 5 to centimeters lateral to the midline. First identify ribs. Ribs have a round contour, and then start to move the probe medially, and till the time we get a transverse squared off contour of the transverse processes. That is the place where we actually start our block. So ribs are round, pleura is well seen. I keep moving my probe towards the medial spinous process. As I keep moving my probe, you will realize another muscle comes into picture. This is the erector spinae plane muscle. And then suddenly the contour will change to a transverse contour. So this is a transverse contour which we are actually looking for. Another important thing is, if you are in a strict perpendicular plane, you will not see the pleura. And if you turn your probe 5 degrees outwards, then you will get to see the pleura. Now I'll be turning my probe 5 degrees outwards and you get to see the pleura as well as superior costotransverse ligament. Let's look at a video. So right hand of the screen is a caudal. Left hand of the screen is cranial. So my needle is going to come from caudal to cranial in plane approach. And the aim is to hit the transverse process, do a test injection. Once we see ESP getting lifted off the transverse process, then the remainder of the injection can be done. And we can observe the spread of the drug in 2 to 3 spaces cranial as well as 2 to 3 spaces caudal. So the next question which comes to our mind is, as anesthetists, where exactly to inject? On the top surface, on the edge, or in between two transverse processes? So there have been a couple of letter to editors, and it has been my personal observation that if we are injecting closer to the edge or in between two transverse processes, then the drug has a much brighter chance of reaching the paravertebral space. So that is why my recommendation is to inject at the edge or in between two transverse processes. So another approach which has been described in literature is the transverse approach to the erector spinae plane block. So whosoever has attempted this block would have realized that at some times we have given intramuscular injections, which causes these kinds of laminations. So in order to circumvent this problem, there have been 3 papers in the literature which have actually described the benefit of a transverse approach, where this kind of a side effect can be recognized much earlier, and then you can place the needle into a deeper plane. So one can definitely give it a try, and in case you are facing problem with the parasitical orientation. My friends, the next question comes to mind: is it effective clinically? It is effective. There have been so many RCTs. I'm quoting one of the meta-analysis where it was effective and it was almost comparable to the thoracic paravertebral block. This is another one which has been published very recently in Pain Physician 2021, and they concluded that in this erector spinae plane block is superior to systemic analgesics as well as an alternative to paravertebral block. So now we have coming to the regional anesthesia techniques which can be used for enteromedial chest wall. The target in this case is the anterior cutaneous branch of the intercostal block. It can be between two muscles like pec major and the internal intercostal, or subsequently in a deeper plane, that is the internal intercostal and transverse thoracic muscle. So two blocks have been described. One is the PIFP block, that is the pectointercostal facial plane block. In 2014, it's essentially a UST guided musculofacial plane block, which targets the anterior cutaneous branches, and the LA is deposited to pec major, as I've shown you in the figure. So this is how we can do this block. Patient is supine, a high frequency linear probe has to be placed 3 centimeters lateral to the sternum, in plane approach, caudal to cranial, and we deposit 15 mL of ropivacaine 0.375%. So this is a small video. This is pec major intercostals. The needle is coming from caudal to cranial direction, and we aim to separate the plane between pec major and the intercostals. So it is also a basic level block which can be done, and it should be done for a breast surgeries, particularly involving the medial half of the breast. So coming on to a deeper block, which is the transversus thoracic muscle plane block. It was described by Ushima and colleagues in 2015. Here the LA is deposited one layer deeper, but it is a dangerous block to me, because in this plane runs the internal memory artery, and transversus thoracic muscle, as I'll show you in this figure, is almost hypoechoic. And the artery running in this plane can, in majority of the cases, cannot be identified as beginners. So I would request you not to attempt this block till the time you are an expert in this field of regional anesthesia. And the previous one, the PIFP, can solve the same purpose. Why not do that? So if you attempt, please realize that there is an internal memory artery which is sitting very close to it. So you have to be careful. So my dear friends, are you confused listening to my presentation? I presented you so many blocks, but now I'll solve each and every confusion. I'll do a good review of literature and tell you which block is to be done in which chest wall surgery. So when we actually talk about chest wall surgeries, there are 4 major surgeries which we are looking for as anesthetists: thoracotomies, VATS, breast surgeries, and rib fractures. So the choice of block will depend exactly the expertise of the anesthetist, where exactly is the surgical incision, and facilities for acute pain services are available or not. So let's come on to the thoracotomy. As whosoever has given anesthesia for thoracotomies would realize these are one of the most painful incisions, and we get pain because of nociceptive somatic pain. We also get pain because of stretching and injury to viscera, and there is certainly a component of referred pain to ipsilateral shoulder, as well as there is a component of neuropathic pain. So Prospect Group, which is a very prestigious groups working since almost 20 years, where they formulate guidelines for post-operative pain management. You can go to their website. They are easily downloadable. So in 2015, it has been almost 7 years, and they are due for review for thoracotomies. They stated that paravertebral block should be preferred as the first choice in comparison to thoracic epidural analgesia, because due to lower complication rates. And remember, thoracic epidural will always give you a bilateral effect. And in case you cannot use a paravertebral, then you can think of thoracic epidural. And third is my recommendation that in case you are not that expert citing a paravertebral or a epidural analgesia, please use ESP, and a catheter can be easily inserted. We have done it number of times, and infusions can be used at 4 to 6 ml per hour. What about breast surgeries? We do a lot of breast surgeries, and the Prospect Group came out with guidelines in 2020, where they stated that paravertebral as the first option. Second option, they stated pectoral nerves. But you have to remember that pecs 2 and serratus anterior will not cover the medial half of the breast. So these are my recommendations. Please use PIFP whenever you're using pecs 2 or SAP. And my personal favorite is ESP. So how do I decide whether I have to use pecs or SAP or ESP? It's very simple. If the BMI is around 30 and all, and the patient can be turned to its lateral side, I generally prefer ESP. If the BMI is on the higher side, then my personal preference is SAP with PIFP, and I do prior to the incision, whereas ESP in our department, we do after the surgery is over. So what about VATS? These days, it's an era of minimally invasive surgeries, and VATS is a quite popular surgery. So Prospect Group came up with guidelines in 2021. They are very recent. and they recommend thoracic paravertebral or erector spinae as the first choice. So ESP, although 5 years old, is gaining momentum and is definitely featuring out in our guidelines. And serratus anterior plane block was the second choice. So my personal preference for VATS is ESP. What about rib fractures? As anesthetists, we are called by our intensive care friends to give some kind of analgesia to their patients for rib fractures. So, how do we take a decision? This is a beautiful article which I'll request everyone to go through, published very recently in BJA. So, what should be our plan for rib fractures? If the fractures are situated anteriorly or in the lateral chest wall, but the patient is obese, is not able to sit, roll, and will not give a good position for paravertebral, then we go for serratus anterior plane block. And if the patient has a posterior or lateral fractures, unilateral, but is able to sit or roll to one side, then you have choices like you can go for erector spinae, serratus anterior, paravertebral. And if you have bilateral fractures, then the choice obviously is thoracic epidural at first instance, or a bilateral paravertebral, or a bilateral erector spinae, or a bilateral serratus anterior plane block. So what are the risk and the complications of thoracic wall blocks? So they generally in these planes, we have some vessels running. So there is definitely a risk of puncture to that vessels, hematoma. And for PEX2 serratus anterior, there is a risk of pneumothorax as a beginner if you are not able to visualize your needle well and you are advancing your needle without actual visualization. And obviously, last is a theoretical concern. So generally, it takes 30 minutes for the drug levels to reach their peak plasma concentration. So request everyone to monitor these patients for at least 30 minutes. So there is a lot of confusion regarding nomenclature of the chest wall blocks. So ASRA and ESRA, reputed societies for regional anesthesia, their experts came together and they did some research on basis on the Delphi consensus study. And in 2021 in RAPM, they published the standards which should be used for nomenclature. So in chest wall, SAP is acceptable. For PIFP, they stated that it should be labeled as superficial parasternal intercostal plane block. Makes sense also. For transversus thoracic plane block, they suggested that you should use the word deep parasternal intercostal plane block. PEX1 and PEX2 are out of their recommendation. For PEX1, they stated because you deposit the drug between PEC major and PEC minor, it should be called as interpectoral plane block. And PEX2, because we deposit the drug between PEX minor and serratus anterior, it should be called as pectoserratus plane block. So henceforth, whatever, if you are planning to publish any RCTs, please change your terminology according to this Delphi consensus. So any contraindications? These are usual, that is the patient refusal, allergy, infection at the site of injection. And what about coagulopathy? So if we look at the guidelines by our ASRA, fourth edition, they stated for blocks other than neuraxial, deep peripheral nerve blocks, the management should be governed by consideration of three important things: the vascularity of the space, if actually the vessel punctures, whether you will be able to compress it or not, and if you're not able to compress it, what are the consequences of the bleeding. So they didn't mention which side of blocks, but they made a general comment. But very recently, 1 month back, the European Society for Anesthesia and Intensive Critical Care, as well as Regional Anesthesia Society, came up with some guidelines where they clearly stated which blocks can be done on anticoagulants, which cannot be done. So deep blocks should be avoided. So in context of thoracic wall, you have to avoid epidurals as well as paravertebral, but you can certainly use parasternal blocks, serratus anterior, erector spinae, intercostal, as well as PEX block. But as a word of caution, I'll introduce the deep parasternal intercostal plane block or the transversus thoracic plane block. It's very close to internal mammary artery, although they're recommended, but these recommendations are for experienced anesthesiologists. As a beginner, do not attempt in an anticoagulated patient. So now I have almost covered majority of the blocks, their review of literature, the recommendations. I'll share what is my contribution towards thoracic wall blocks. In response to Blanco's article in 2013 regarding serratus anterior plane block, we wrote a letter to editor in the anesthesia journal in which he had published that serratus anterior will not cover the medial portion of the breast. So I said that you have to deposit the drug between pec major and intercostal, and I called this block as pec major plane block. And you will recollect from my previous slides that subsequently in 2014, PIFB, which is nothing but what I had described in literature, was described by Torr and colleagues. Our second contribution towards erector spinae is all those who have attempted erector spinal plane block using an in-plane parasagittal orientation would have realized that it is a steep trajectory block. At times, you may lose the sight of the needle. That is why we described in literature published very recently in 2020, Anesthesia, Pain and Intensive Care, the outer plane approach to erector spinal plane block. So I'll show you a small video. This is the standard of care we normally follow in our department. You can appreciate the needle coming from the anterior towards the posterior surface, and I'm attempting to hit the needle in the transverse process. Once I hit, I give a test injection, and subsequently the main injection is given, and you can very well appreciate the entire ESP getting lifted off the transverse process. So I call this as a beginner's block because this can be very easily done. And if you have residents under you or a fellowship candidates, you can certainly teach them. It's an easy block to perform in the outer plane approach. And once they gain proficiency, then you can ask them to switch over to in-plane approach. So this is an excellent infographic by Dr. Sergi Boada-Pai. He's available on Twitter. You can just subscribe to his Twitter handle, and you will realize he publishes so many of the images. This is one of the image. You can take a screenshot, and once you have time, you can just go through. It is just a summary of whatever blocks are available for chest block, and majority of them I have covered in my lecture. So these are good quality references. You can take a screenshot for them, and these are free in Google. And in case you face any problem, you let me know. I'll be more than happy to share these references. My lecture has been prepared using these high quality references. So it was a complex kind of a topic. So I have tried my level best to resolve all the complexities. Thank you very much for patient listening. And in case you have any questions, I'll be more than happy to answer.
Thank you, Deveshwar. Very excellent three-pronged approach. That is literature review, video presentation, and pictorial images. Very excellent, sir. Easy to
Thank you very much, sir. Thank you.
Thank you very much to have you again, sir.
It's a pleasure.
It was also wonderful. Wonderful, sir.
Thank you very much. Thank you
so much. I think all the messages are only thanking you. No other questions.
So it makes things easy for me. No more questions.
Thank you, sir. Thank you. It was nice to have you again. Thank you.
Thank you very much. Pleasure is all mine.
With that, we come to the end of this session. So we will meet once again the next week with more interesting topics. Thank you, the today's speakers, Deveshwar, Ranjit, and Guru Sandhya. Thank you so much for your contribution. Thank you, sir.
Thank you, sir.
Thank you. We close this session. Shilpa, we can close this session. Thank you.